We'll start the second session, second plenary sessions. I'm very delighted to have Professor Salah Rashid as co-chairman. Our first speaker for the session is Professor Jacques Donnet. The topic for today is myoma-related Professor Jacques Donnet. The topic for today is myoma-related infertility, how to manage surgery or medical therapy. Please.
Mr. Chairman, ladies and gentlemen, I will share with you some data about myoma-related and myoma will grow. And there are several factors influencing the growth of uterine fibroids. And of course, race and age are the most well-known factors. And indeed, there is a difference between the black population and the white population, and this difference in the prevalence continue over the age. And as everybody knows, there is an increasing rate, an increasing prevalence according to the age. But the real question is, there are several factors controlling the fibroid's growth: the genetic alteration, the environmental factors, the autocrine factors, but of course, the endocrine factors. Mistake. Indeed, when we analyze this cartoon, we see that the progesterone can lead to the cytosol progesterone receptor as well as the nuclear progesterone receptors and influence through several pathways the proliferation and the apoptosis. So that progesterone is very important, and we know now that the progesterone receptors content is 3 times higher in the myoma when compared to the myometrium. So that a review mentioned that there is a lack of evidence of the efficacy of progestogen therapy in uterine fibroids treatment. And in fact, progesterone and progestogens play a critical role. It's when you give progestogens to somebody with myoma, it's like add fuel to the fire. So that, in relation with my lecture, I would like to discuss with you the mechanism by which fertility could be impaired by the presence of myoma. And of course, uterine cavity distortion, it's obvious factors. If you have a submucosal myoma, like this myoma, of course it will interfere with the implantation of the blastocyst. But of course, impaired endometrial and myometrial blood supply are influenced by the presence of intramural myoma and could interfere with some factors influencing the endometrium. An increased uterine contractility has been also demonstrated. But the most important and more recent event is the gene expression of the OXA10. And in a paper published recently, in fact in 2 different papers, it was demonstrated 3. And TGF-beta3 may influence the expression of OXA10. It means that in myoma of type 2, here, there is a huge secretion of TGF-beta3, and due to the presence close to the endometrium, it influences the OXA10 expression. But 2 factors are crucial, of course. The size of the myoma, of course, bigger is the myoma, more important is the secretion of TGF-beta3, and the proximity of the uterine cavity. If it's very close to the endometrium, it will influence, of course, the OXA10 expression. For the type 3, very close, it's influenced too, and for the type 4, we don't know exactly. It has been proposed for the management of uterine fibroid, surely if they are causing infertility. Let me start by hysteroscopic myomectomy. And of course, hysteroscopic myomectomy is really indicated in case of type 0, type 1, and type 2 myoma in most of the cases. In fact, this technique is very well known, not dangerous. In experienced hands, it gives excellent result in terms of fertility. Looking at the algorithm, first, a medical therapy to decrease the size of the myoma and to decrease the risk of a second hysteroscopy to manage completely the myoma. Thus, medical therapy before hysteroscopic myomectomy. In some cases, but infrequent cases, the response is so good that no need for a further hysteroscopic myomectomy. The question is more important if we consider the intramural myoma. Should we treat surgically? But we should take into account the risk of myomectomy. And the main risk is the bleeding during surgery, but of course the impact on you risk of repeated surgery if we do the surgery in a very young woman. For example, if you do so that we should think about benefits of medical therapy. And the benefits of medical therapy are to avoid surgery or allow minimal invasivity preservation is the goal. And we published 2 years ago and last year what we call the migration effect. If you keep in mind the action of the TGF-beta3 and oxaten, if we are able to decrease the size of the myoma and to push it back far away from the uterine cavity, we will decrease the influence of this myoma. It's what we call the migration effect and what we expected to do. Decrease the size and push it back, thus transform a type 2 myoma. EMA decide to restrict the indication to very limited indication, and in fact, I never prescribe. And I guess that any gynecologist will dare to prescribe again ulipristal acetate because of the risk of medico-legal action. In fact, only 7 cases of DILI, this liver injuries, were demonstrated after the taking of ulipristal acetate on over 1 million of patients. But nevertheless, the decision has been taken by EMA. The question is this: are we a new alternative? Yes, the oral GnRH antagonist. In fact, when we compare to the natural GnRH agonist, there are huge differences. And let me stress on the huge difference between GnRH agonist and GnRH. GnRH agonist first stimulate the gonadotrophin, it's what we call the flare-up effect, followed by the down-regulation of the receptors, and finally, after 1 month, a iatrogenic menopause is induced. With the GnRH antagonist, there is a competitive binding to GnRH receptors. All receptors are blocked. There is no flare-up effect. There is no activation by endogenous receptors. In fact, look at the right side of the slide. The clinical benefits of GnRH antagonists are oral delivery, rapid reversibility, which is very important for women treated for infertility, immediate gonadotrophin suppression effect, and a dose-dependent, it could be a partial or a full suppression of estrogens secretion depending on the dose. And in fact, if you look the estradiol level, this in yellow is during the cycle. after treatment by GnRH agonist is a full suppression. With GnRH antagonist at low dose, we are in the optimal zone where there are benefits without bone loss. In case of full suppression, you have very low estradiol, and if you add that back, you are back in the optimal zone when the side effects are really minimal. 3 papers, one in the New England Journal about elagolix, one in the New England Journal last year about relugolix, and one in the Lancet 1 month ago treated the linzagolix with or without add-back therapy. And if I summarize the data, comparing elagolix, we were able to stop the heavy menstrual bleeding. Looking at the amenorrhea, I have to mention that all these women have heavy menstrual bleeding at the time of menstruation. And you look that more than 50% of these women with the treatment are in amenorrhea. Thus, high dose of oral antagonist plus add-back. And the conclusion of the 3 papers, and the 3 drugs are very effective. They are effective in reducing heavy menstrual bleeding in women with uterine fibroids and preserve bone mineral density. But due to the add-back, there is a poor response in the myoma size, so that in case of infertility into the myometrium, linzagolix without add-back and relugolix without demonstrate that they are able to reduce of more than 50%. Thus, there are relevant strategy when volume reduction is a priority. Indeed, I come back to the migration effect and what we expect. And what are the results of GnRH antagonist alone, thus without add-back? You see here, surrounded by the red circle, that we have used linzagolix plus add-back with a poor response, and the more significant response is obtained when linzagolix alone is given for 3 months. Of course, we know that in that case, the estradiol suppression is very strong, very severe. You see here that under linzagolix 200 milligram, the level of estradiol is more or less 10 picogram, thus we are very active about the reduction of myoma size. It's not the case when the add is a potential relevant strategy. A case of young women with a multiple myoma and a big myoma in the posterior wall, and after 3 months of GnRH antagonist alone without add-back, a significant reduction of more than 60% was observed. And the same result were observed in transversal view. Of course, when you discuss with a woman the fibroid size and the risk of add-back is vascular event, thromboembolic disorder, so that when you discuss a patient, individualized approach is recommended based on clinical profile, baseline risk, and the goal you would like to achieve. And that is, no doubt, is the rule. But in case of type 2, more than 3 centimeters of multiple intramural myoma, depending on the age and the value of AMH, maybe there is a place for GnRH antagonist. If we are able to reduce the size of the myoma and to restore the uterine cavity, why not organize immediately the transfer of the embryo, which can be performed 2 weeks after the after the end of therapy. Why? Because before starting medical therapy, we will propose oversight vitrification. Let's start with oversight vitrification, then medical therapy 3 months, and because we know that the reversibility of the drug is very quick and that the first ovulation occurs 2 weeks after the end of therapy, why not organize the transfer of the embryo 2 weeks after the end of therapy before a possible regrowth, of course, of the myoma after the end of therapy. And of course, in case of no restoration, there is still a place for surgery. And the conclusion of my lecture is, of course, there is still a place for surgical therapy, but maybe we have to think more and more to the possibility of a medical therapy before surgery. Thank you very much for your attention.
Thank you very much for a very elegant presentation. We have a time for 1 or 2 questions. Please, Professor Selp. Yes.
Very brief. I just want to say that was a spectacular talk. We've always wrestled with what to do with a fibroid that is right on the uterine lining but not impinging. You can't really see it hysteroscopically. And I would guess what you're saying is this is the best way to treat it. Am I correct on that?
Thanks, Professor. What is the age limit of the use of medical therapy in infertile patients? Age limit for the use of medical therapy as alternative in fibroid patient.
As alternative?
Yeah.
In which condition? Epimenstrual bleeding or infertility?
Infertility.
Yes. I guess that in several conditions, of course, we have to discuss with the patient, but for me the indication is the size of type 3 myoma and several big myoma. The goal is to restore the uterine cavity because in infertility, all review and meta-analysis demonstrate that if you do IVF in patients with a myoma, if the uterine cavity is distorted, so that if you are able to restore the uterine cavity, why not use first a medical therapy? I guess that the best indication is the distortion of the uterine cavity. And if you are able to restore that before going to IVF, it may be successful. But again, we need randomized control study to prove that.
Thank you, Professor Donez. Is there the role of uterine embolization for the reducing the size of the fibroid? Because it's becoming, does it affect the implantation? Does it affect the uterine supply? Or still we're free to use it? Because it will reduce the size of the fibroid tremendously. But my question, does it affect the receptivity?
Analysis, I don't fully agree with that, but in case they examine more than 20,000 cycles of IVF, and they demonstrate that even in case of intramural myoma of 3 centimeters, they influence the implantation rate. So that, I don't know exactly the limit of the size for which we have to treat or not, but I guess that if we can go to IVF without a surgery, and if a medical therapy allows to go to IVF directly, I guess it's a benefit for the patient.
I guess his question was the effect of embolization.
Embolization. For the embolization, in fact, I have a slide. There is no study about the benefits of uterine embolization in case of myoma-related infertility. And the conclusion of all the meta-analysis that if the patient desires to get pregnant, there is no question to propose uterine embolization because complications during the pregnancy are very important. I'm sorry I didn't understood because I'm some noise from the back.
Okay, thank you very much.
Thank you.
Thank you.
Thank you again, Professor Donate. And it's my pleasure to introduce another leader in the field of IVF. That's Professor Charles Chaperon. He's Professor of Obstetrics and Gynecology, Paris University, France. Professor Chaperon will address the topic of modern management of adenomyosis. Yes, Professor.
No, it's okay. Excuse me. Thank you very much, Mr. Chairman, for this kind introduction. First of all, I would like to tell you how I'm very happy to be in Egypt since this COVID pandemic. We lose this meeting for 3 or 4 years, and I would like to thank and to congratulate the president of this conference, my friend, Professor Gamal Serrour, for inviting me and for his friendship. Thank you so much, Gamal. So we are going to speak about a difficult topic concerning the adenomyosis. I'd like first to thank all the people in the department who collaborate with me for the management and the research, scientific and clinical research for the patients. So first we will go to discuss together about the diagnosis and after to see about the management. There are 3 main clinical symptoms concerning the adenomyosis: the pelvic pain, the heavy menstrual bleeding, and the infertility and the miscarriage. And you have numerous data who demonstrate that because of the adenomyosis, you have menorrhagia, you have impact on the fertility, natural fertilization or in vitro fertilization, and what is very important in the management, an impact on the pelvic pain. Recently, a meta-analysis demonstrated clearly with the IVF or ICSI that the impact on adenomyosis will decrease significantly the live birth rate and will increase the risk of miscarriage. And recently, it was published 2 months ago in the department, we look at the impact on the live birth rate of the association of adenomyosis to endometriosis. And we clearly demonstrated that when you have an associated adenomyosis, you significantly decrease the live birth rate in ART, and what model you use to perform the meta-analysis, you can see the impact of the age, the impact of the ovarian reserve, and the impact, the presence of adenomyosis. And on the opposite, when you look at the association to an endometriosis to the adenomyosis concerning the spontaneously early miscarriage rate, we demonstrate that the association of these 2 diseases will significantly increase the risk of miscarriage, and this is specifically observed when you have a diffuse adenomyosis rather than you have a focal adenomyosis. And when you look at the multivariable analysis, this observation is specifically important for the patient with deep infiltrating endometriosis. But very interesting, you have now new papers who look at the impact of the adenomyosis on the quality of life. And in the team of Carmona in Barcelona, they demonstrate that concerning the quality of life, you have no difference between the adenomyotic patients and the deep endometriotic patient. But if you compare the adenomyosis patient with no adenomyosis or no deep endometriosis patient, you have a significantly negative impact of the adenomyosis on the sexual life of the patients. They look also in the same department with different questionnaires on the quality of life and mental health for the patient, and you can see also the negative impact of the adenomyosis. And finally, they look at the impact concerning the work impairments and the cost of the management, and it is significantly negatively affected when you have adenomyosis. So all these elements are very important to take into account for the management of these patients. So what are the clinical symptoms of the endometriosis? You have the abnormal uterine bleeding, the gynecological pain symptoms, the infertility or recurrent miscarriage, local pressure, and gastrointestinal or urinary tract symptoms. But what are the problems of these clinical symptoms? First, you have a great heterogeneity concerning the symptoms. None of these symptoms are specific of the adenomyosis. So with the questionnaire, the clinical examination, you can have only a suspicious of adenomyosis, and you must not forget that in 30% of the cases, the disease is asymptomatic. It is the reason why we need to work with the radiology in order to improve the diagnosis of the endometriosis. And first, you will use the transvaginal ultrasonography, and you have numerous parameters which demonstrate that it's perfectly possible to perform the diagnosis of the adenomyosis. It was published in the consensus, the MUSA consensus in Europe, and it will be possible to have the diagnosis of the endometriosis. The other option is the MRI, and on this slide you can see that you have not only an adenomyosis, but also a focal posterior adenomyosis related to an endometriosis bowel nodule near the torus uterinum of the patients. And the recent meta-analysis demonstrate clearly that the specificity and the sensitivity of these two options, transvaginal ultrasonography or MRIs, give comparable results concerning the possibility of the diagnosis of adenomyosis. And when you look for the transvaginal ultrasonography, it seems that the best criteria to perform the diagnosis is the echogenic subendometrial lines and buds. So all these elements are very important. Why? Because previously the prevalence of the endometriosis was completely unsuspected. And now we know, because of the use of the MRI or the possibility of the transvaginal ultrasonography, that this disease is very frequent even in the young patients. And you can see that in the left part of the slide, it was a publication from Professor Petraglia in Florence, in Italy, and it demonstrates clearly that for patients very young, 24 years old, he obtained with the transvaginal ultrasonography a diagnosis of adenomyosis in 30% of the patients. That wants to say that 1 out of 3 patients you see in your consultation, they have an adenomyosis even if they are very young. And in parallel, without any connection, we do exactly the same study in Paris with the MRI. And what we observed, exactly the same percentage for patients by mean 30 years old, we have 30% of adenomyosis at the MRI. Possibility for the future to improve the diagnosis with the transvaginal ultrasonography is to perform the measurement of the stiffness of the myometrium, and you can see that you have a significantly increase for the patient with adenomyosis. And what is very interesting, it is a recent paper from Guo in China. It demonstrates clearly that the myometrial stiffness value is correlated to the importance of the heavy menstrual bleeding, and it's correlated also to the severity of the dysmenorrhea, the fact that you have an adenomyosis, and the uterine size. So the frequency, the prevalence is very important. But as for the endometriosis, you have three phenotypes with the superficial lesions, the oma, and the deep nodules. We have also a great heterogeneity for the adenomyotic patients. So you have numerous classification of the adenomyosis. You can have the diffuse adenomyosis. You can have the focal, the local, the adenomyoma, an intramural cyst. And you can have also what we call the focal adenomyosis, either in the anterior part of the uterine wall or in the posterior part of the uterine wall. And if we look at our experience in Paris concerning the association between the deep endometriosis and the focal adenomyosis, you can see that in our experience, in 50% of the cases, when you have a deep endometriosis, you have an associated focal adenomyosis, and this rate is 70% in cases of intestinal endometriosis. So what are the relationship between endometriosis and adenomyosis? We look at the patient with diffuse adenomyosis, and we demonstrate that the percentage, the prevalence of the diffuse adenomyosis is exactly the same. 30% of the cases, whatever you have endometriosis or not. And the second point is that there is no correlation between the endometriosis phenotype and the occurrence of the diffuse form of the adenomyosis. For the focal adenomyosis, is a completely different story. The focal adenomyosis is not observed in the patient without endometriosis. It is in relation with endometriosis, and the association is correlated with the endometriosis phenotype and significantly observed for the patient with deep infiltrating endometriosis. So perhaps, because of this clinical observation, we have two different pathogenesis for this disease. First, for the diffuse adenomyosis, a progression from the endometrium into the myometrium, and perhaps because of the association between the focal adenomyosis and the deep endometriosis, after the regurgitation, if there is the possibility to infiltrate the intestinal wall, why it is not possible for these endometriotic cells to penetrate in the posterior wall of the uterus. And this is confirmed by these Japanese publications, who demonstrate clearly that perhaps you have different pathogenesis to explain the adenomyosis first, and second, the relationship between adenomyosis and endometriosis. And when we look at this study from Kishi in Japan, who published a very good paper on the adenomyosis, he performed the classification with intrinsic one and the extrinsic one. And he demonstrated that it was not the same disease. He demonstrated that you have significantly more posterior endometriosis in the pouch of the Douglas for the patient with intrinsic phenotype compared to the intrinsic one. And if we compare to our results in Paris, it is exactly the same results. That's once we said what Kishi called the intrinsic form is what we call the diffuse form, and what is extrinsic for Kishi is the focal form in the French classification. So if we have different pathogenesis, it is an hypothesis, it needs to be confirmed in the future. We can look at the clinical observations. And in our experience, it seems that when we look at the isolated diffuse adenomyosis versus the isolated focal, it seems to be not the same disease in the clinical observation. For the isolated focal adenomyosis, you have significantly lower body mass index, and it is correlated to significantly more surgery for uterine surgery and endometriosis. And I think that it is normal because we demonstrate that we have a strong association between focal adenomyosis and endometriosis. And for the diffuse adenomyosis, it's different. It is significantly more associated to the heavy menstrual bleeding compared to the focal adenomyosis. And this is reinforced by the recent paper from the team of Guo in Shanghai, who look at the stiffness of the myometrium to the ultrasonography according to the importance of the heavy menstrual bleeding. And you can see that the lesional stiffness is significantly more important if you have excessive heavy menstrual bleeding, and there is a correlation with the hemoglobin level and the uterine size. So we can postulate that adenomyosis is also, as the endometriosis, an heterogeneous disease, because you have different pathogenesis, you have different clinical signs, and when we look in our experience, you can see that the age is significantly completely different for the isolated focal and the isolated diffuse adenomyosis. And finally, when you look at the relationship between adenomyosis and infertility, it seems that, in our experience, the infertility is significantly correlated to the isolated option with the medical treatment, hormonal or non-hormonal. You can try to induce necrosis by embolization or HIFU, or you can perform different type of surgery, conservative or radical. The medical treatment with the IUD with levonorgestrel in a systematic review demonstrates clearly that it is a very satisfactory option to treat the patient with adenomyosis. And what is important is satisfactory results concerning the impact of the levonorgestrel on the heavy menstrual bleeding. And if you compare the IUD with the hysterectomy, you can see that the impact on the menstruation is exactly the same, but the quality of life is better for the patient with the medical treatment. The advantage of the IUD is that it is as efficient whatever the phenotype of the adenomyosis. Recently in Japan, very interesting paper from the team of Osuga, who they look at the type of the adenomyosis. And in the same paper, they look also at the impact of the IUD on the visual analog score, and they demonstrate the efficiency of the levonorgestrel IUD. And as for the menstruation, the benefit, the efficiency is more observed for the patient with the incipient type. Another excellent study from Japan, from Arada, who look at the impact in this prospective multicenter study. It demonstrates clearly the positive results, whatever the objective is to treat the heavy menstrual bleeding or the dysmenorrhea, and the result is exactly the same, whatever dysmenorrhea, heavy menstrual bleeding, endometriosis, or uterine myoma. And in this paper also, it demonstrates clearly the positive impact of the IUD, the risk of expulsion of the IUD, and he demonstrated it was less than 10%, 9%, and the risk factor after multivariable analysis are the body mass index, the fact that you have an adenomyosis, and the uterine cavity length. The other option for the medical treatment can be the Dynogest, and Ozuka also demonstrates clearly with a randomized trial that not only the Dynogest is efficient, but it is also very well correlated for the patients. And when you compare the Dynogest with the Generate analog, that's true that perhaps the Generate analog seems to be more efficient to decrease the bleeding and the uterine volume, but you have, with the two drugs, with the two options, the same efficiency on the pelvic pain symptoms. Comparison between the levonorgestrel and oral contraceptive pills, only one prospective study, randomized study, who demonstrate that you have comparable improvement at 6 months in the two groups, but the improvement is significantly better for the IUD with levonorgestrel. As for the myoma, like Professor Donnet said, you will have in the future new of the antagonist for the endometriosis and the myoma. I'm sure it will be also a good indication to try these drugs for the patient with adenomyosis. The uterine artery embolization can be, in selected cases, a good option for patients for which the medical treatment doesn't work or for which the surgery is difficult or risky. And you have also the possibility of HIFU, and you can see that after 3 or 6 months of HIFU, you have a significant reduction in the uterine size and in the adenomyosis. All these possibilities are infertility. So the problem in the daily practice also is how to manage the patient with adenomyosis who want to be pregnant, how to choose between the surgery and the ART. The majority of the paper concerning the surgery of the adenomyosis came from Japan. And the most important publisher is Professor Osada. It's very difficult surgery, very hemorrhagic surgery with some risk after concerning the obstetric outcome. He obtained 60% of pregnancy. But what is important in this series is to look at the results of this pregnancy. He performed very difficult and risky surgery, and 75% of the pregnancy are obtained with the IVF. And all the delivery were performed by C-section. Another very interesting paper of Kishi, he demonstrated clearly the importance of the age. There is no place for the surgery if the patients are more than 39 years old. And he demonstrated also, like from Osuga, that 50%, a little less, of the pregnancy after the surgery are obtained with the IVF. And what is interesting in this paper from Kishi, he looked with a multivariate analysis to try to define what are the risk factors which impact the results of this conservative surgery. He demonstrated that you have two negative impact factors. First, what is normal, the age. And the second, which is very, very, very interesting, is the fact that you have a posterior wall involvement. That wants to say that the fact that you have a posterior focal adenomyosis. And in our experience in Paris, when you look at the patient with deep endometriosis and an association with a posterior focal adenomyosis, we demonstrate that these patients are the patients with the more severe cases of the deep endometriosis, with significantly more multifocality of the deep nodule, significantly more infiltration of the intestinal wall, significantly more number of deep nodules in the intestinal wall, and significantly more ovarian endometrioma. That wants to say that you will have not only a difficult surgery to perform the adenomyosis management, but because of the association of the focal nodule, you will have also a very difficult surgery concerning the surgery of the deep endometriosis by laparoscopy between the fact that you have an adenomyosis and the fact that you have associated adenomyosis to the deep endometriosis. And you can see that the risk factor related, the necessity to perform bowel resection, the necessity to perform an hysterectomy, and the existence of an adenomyosis. So all these results from Barcelona and Paris go exactly in the same direction than those observed by Kishi in Japan. And finally, the parameter which is in favor for Kishi to perform the conservative surgery is the fact that you have previous failure for IVF treatment. Which failure of IVF treatment, he obtained 60% of pregnancy. But what is important also is to look at the result. 90% of this pregnancy were obtained with the IVF. So I think that for this patient, if the surgery has some benefits after the IVF, why not to perform systematically in the first step the IVF procedure rather than the difficult surgery? How to perform the IVF for this patient with adenomyosis? It is now well recognized and demonstrated scientifically that you need to use long protocol with desensibilization. The generation antagonists are very helpful in the management of this patient because it will decrease significantly the risk of miscarriage. And if you use the frozen transfer, it will be interesting, as it was demonstrated in this Chinese, and we have exactly the same result in the department, with the downregulation to use an HRT prescription before to perform the frozen transfer. And what could be the place of the frozen transfer for this patient with adenomyosis and ART? We look, in our experience, at the benefit to perform frozen transfer for the patients which are submitted for publication. Each time you perform a frozen transfer, you will increase the chance of pregnancy. But you can see that the rate, the benefit of the frozen transfer is significantly more important for these endometriotic patients when they have an associated adenomyosis. That's one to say that in the previous part, we tried to systematically perform frozen transfer for the endometriotic patient, and now we modify slightly our management, and we propose first the frozen transfer for the patient endometriosis and adenomyosis. The duration of prescription of estrogen needs to be 28 days. And if we want to conclude, questioning and the clinical examination, you will have only a suspicion of adenomyosis. So the revolution during the last 10 years is the possibility of the radiology, first imaging process, the transvaginal ultrasonography and or MRI, and you will have the confirmation of not only the adenomyosis, but of the phenotype of the disease. It is an heterogeneous disease. Whatever the classification, the Japanese one, the French one, there is a lot of classification. You have diffuse adenomyosis and focal adenomyosis. In my opinion, the strong collaboration between the gynecologist and the radiologist, the key point in the management and in the diagnosis is the radiology, because you will confirm the diagnosis. Second, you will know if there is or not an associated endometriosis, and you will precise the phenotype of the endometriosis, and you must be obsessed to know if there is or not a focal adenomyosis. Why? Because focal adenomyosis is a marker of the severity of the deep endometriosis when you have an associated deep endometriosis, and it seems that this focal adenomyosis is a negative prognosis factor for the fertility of the patients. So the management will depend on the age, surely from the patient's intention and priority, the clinical signs, IUB, pelvic pain, and or desire of pregnancy, the phenotype of adenomyosis, the association or not of an endometriosis, and also, as it is well presented in the Palm-Cohen classification, if you are or not some associated other hemorrhagic disease. So we can summarize for the patient with heavy menstrual bleeding. The first question will be, is there any infertility situation? And I think that if the patient is infertile, because of all the results we demonstrate, I think that if she is not spontaneously pregnant, because it is not because you have adenomyosis that you will be systematically infertile. But if she is not spontaneously pregnant, I think that you need to perform first an ART, and why not, according to the result of Kishi, to discuss of the limited place of the surgery if you have 2 ART failure. If there is no infertility, the question is, do you want to have some pregnancy? If you don't want to have pregnancy, I think it is like Jack said, and you see that we have the same evolution for the myoma, for the adenomyosis, for the endometriosis. We are completely, we change of paradigm for this patient. You will prescribe the medical treatment, and I think that with the Dynogest or with the IUD with levonorgestrel, we have very, very excellent results with few side effects, cost effective on the long term. And if these medical treatments are not efficient, or if the patient will refuse, you will discuss the surgery, the uterine embolization, or the IFU. If the patient wants to be pregnant but not immediately, it is a deferred desire of pregnancy, you will prescribe the medical treatment, and when she wants to be pregnant, you will perform the IVF. And if the desire of pregnancy is immediate without infertility, you will perform an ART, as we previously said. And to finalize, I would like to invite all of you to come in 4 months in Abu Dhabi to participate and to share with us concerning your interest with endometriosis, myoma, and uterine disorder in the 9th Congress of the SEUT. Thank you so much.
Thank you, Professor Chapron, for this great presentation. Unfortunately, we are run out of time, and just one comment or question will be allowed. It's okay. If anybody have just one question. Okay.
There is the patient during coloscopy to to find the cystic type, subendometrial cystic types. When we incise, chocolate-like material comes out. This is cystic endometriosis or another thing?
No, I think it is cystic endometriosis. You have the crypt who is arriving near the cavity, and you can perform the incision. The Belgium people from Gortz and so on, they try to do that with satisfactory results.
Why not included in the classification?
Because it's impossible to put all these elements. None of the classification are perfect. So, but perhaps we must take reflection according to the specific point in the future, surely.
Relation between age and debarity for adenomyosis.
Agent?
Age and debarity. Barity.
Parity, yeah.
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 For the occurrence of adenomyosis in our basic teaching, adenomyosis is a disease of high barity, and endometriosis is a disease of low barity.
No, because before we are not able to perform the diagnosis of adenomyosis because we have not the possibility of the radiology. But now we know with the radiology that it's perfectly possible for the patient of 30 years old to have adenomyosis. So I think that we must take care, even for the young patient, the possibility of adenomyosis. And you have three groups of patients: the patient with isolated endometriosis, the patient with isolated adenomyosis, and the patient with a combination of both. And perhaps in the future we will have different management for these three groups of patients.
Thank you.
Yes, thank you. Okay, we'll move to the next speaker, thank you, Professor Chapron. Yes, please, you are a chairperson here, Professor Chapron. Yeah, you are a chairperson here. You want? It's okay. Now our next speaker is Dr. Sven Picker. She will speak. Yes. She will speak virtually. I don't know whether she is ready or not.
Friends and colleagues from the Egyptian Fertility and Sterility Society. Over the next 20 minutes, I'd like to talk about integrated endometriosis treatment. First of all, I'd like to say thank you for the invitation, and thank you in particular to Professor Gamal Serur and Professor Amra El Shalakani for many years of friendship. It's always an honor to work with Egypt. And of course, special thanks to Azza and to everyone else who has been organizing. I apologize that I cannot be there personally. The reason is that I won the election for the AAGL, the American Association of Gynecological Endoscopy, to the board of directors, and the Congress is at the same time. So I had planned to come to Egypt, but now that I was elected, I unfortunately and fortunately at the same time have to go to Denver. So, integrated endometriosis treatment, combining the medical with a surgical approach. A lot of women suffer from endometriosis, and it causes, number one, pain. Number two, infertility. These are the two issues. We call it an enigma, and it's true that we don't know a lot about endometriosis. The reason is that there's not enough research, and that has many, many causes. If you look at Medline, for instance, we find that endometriosis has 31,000 citations, erectile dysfunction 25,000, alopecia 25,000. Considering that endometriosis affects 10% of all women, you realize that the interest is not as big as it should be. Let's get back to the clinic. The real problem is proper and timely diagnosis. We've come to understand that that is the true problem. 7 physicians are consulted before the correct diagnosis has been made, and that leads to an average delay of 6.7 years. This is a publication from 2011, and I hope it's no longer true, but it's not completely off the mark either. What options do we have for conservative treatment? Well, there are 40 Cochrane reviews for endometriosis, so we can see that there's a great level of interest. In red, there are those reviews that deal with medical treatment. Fortunately, I read all of them for you, so you do not actually need to go in there. If anyone wants to check, it's very easy. You just can look up all of these publications. In 2016, the Cochrane Library itself came up with their own review of their own reviews. I have not found any update of that, but basically there's been no change in the data since then either. So they look at 17 Cochrane systematic reviews, 14 reported measures for pain relief, and 8 reported fertility outcomes. What do they conclude? Number 1, here are interventions, medical interventions, that are effective for pain in endometriosis. Number 1, GnRH analogs are effective versus placebo. Number 2, levonorgestrel containing IUDs are effective versus nothing. Number 3, progestogens are effective versus placebo. And number 4, interestingly, laparoscopic surgical interventions also appear to be effective for pain. So this is with regard to pain. How about interventions effective for fertility? Well, assisted reproductive techniques such as IVF, 3 months GnRH agonists improved pregnancy rates. Number 2, excisional surgery improved spontaneous pregnancy rates. Important, spontaneous pregnancy rates 9 to 12 months after surgery versus ablative surgery. Laparoscopic surgery improved live birth and pregnancy rates compared to diagnostic laparoscopy alone. And finally, there's no evidence that medical treatment improved the clinical pregnancy rate. Knowing all this, how do we best manage endometriosis? Well, I'm a surgeon. I love surgery. This is me in the operating room. But endometriosis treatment is not really about surgery. It's about proper management, proper diagnosis, and finding out what the patient wants. This is endometriosis. This is how much surgery is important, and this is how much understanding of the disease is important. If we understand this disease, the most important phrase is treat the symptoms, not the disease. Now, please think about this for a moment. In medical school, we were taught treat the disease, not the symptoms. Only in endometriosis is it exactly the other way around. Treat the symptoms, not the disease, and treat the disease only if it causes direct symptoms. I summarize endometriosis treatment with the 10 Frankfurt key points. Number 1, no diagnosis without laparoscopy. Number 3, no therapy without diagnosis. Number 3, treat the symptoms, not the anatomical disease. Number 4, all treatment resolves around 2 issues, pain and/or infertility. Number 5, there's no cure except hysterectomy, ovarectomy, or menopause. Number 6, never laparotomy, always laparoscopy. Number 7, radical endometriosis surgery. Think about taking a 2-step approach. Number 1, diagnostic, to determine what you want to do and be able to talk with the patient. And number 2, therapeutic, the actual radical surgery. Number 8, you better be a good laparoscopic surgeon before you try true endometriosis surgery. Number 9, talking with the patient about the disease and the options is the most important part of the therapy. Number 10, conservative therapy is as important or even more important than surgery. GnRH analogs can be used short-term, and oral contraceptive pills, progestins, can be used long-term. Primum non nocere. The more you know, the less you operate. But if you operate in endometriosis, you have to go all the way. Well, in the real world, how does that look like? I would say in any woman who has a suspicion of endometriosis, but not a histologic diagnosis, it's absolutely appropriate to start with a medical treatment trial. You have the pill, OCPs, you have progestin-only treatments. Visan is the only EMA and FDA approved medication against endometriosis. It's basically adenogest, so it's a progestin. GnRH analogs can be used, and we have to see how the new oral GnRH antagonists, such as relugolix, actually do. 2. Diagnostic laparoscopy. At some point you need to do that, and it allows you also to do an exam under anesthesia, a rectovaginal examination, which in our day and age should no longer be done on the young patients that we treat. 3. Conservative treatment, if possible. That's always the first step. Finally, fertility treatment if desired. What does the patient really want? Pain relief? Children? This is where in-depth discussions with the patients are important. Number 5, therapeutic laparoscopy, focused on specific pain areas. Number 6, if you go at it, don't be half-hearted. You have to be a radical endometriosis surgeon to master this disease. 7, follow surgery, again with conservative treatment or with pregnancy. It's not enough to excise this disease. It's a chronic disease. It will come back unless you suppress it with medical treatment or with pregnancy. And number 8, the more pain, the more surgery. How does the reality actually look like? Well, I'm not sure whether this movie will survive the transfer. We'll see how we do. You see a horrible endometriosis case. The Douglas is obliterated. The ovary is retracted. The ureters are retracted medially. The ovaries are stuck in the pelvic side wall. And the bowel is also stuck to the posterior wall of the vagina. So it's a miserable and very typical situation. Now, what's special about this? Easy. If this patient has no pain and no desire for fertility, you don't need to do anything. If this patient has desire for fertility, you'll focus on getting her pregnant. If this patient says, I have so much pain, I cannot continue to live, you will offer radical surgery with possible bowel resection. So the same disease, 3 different scenarios, 3 different treatment options. You always treat the symptoms and the desires of the patient. You never treat the actual disease. There's no sense in operating in an asymptomatic woman, no matter how bad her endometriosis is. Chances are you will ruin her life through the operation when before she had only very minor or no complications. Is endometrioma surgery, sacrouterine involvement, rectal endometriosis, nerve sparing. We can't talk about all this, but we'll focus on some of the things. Endometrioma surgery. This is something that every one of us does. If you have a unilateral endometrioma, well, nothing bad can happen. Even if you destroy the ovary, there's always a second one. But bilateral endometriomas, and they're pretty common, they can be very, very dangerous, and you can look very bad if you do not understand what you're doing. All endometrioma resection will lead to a loss of ovarian reserve, no matter how careful you are. The more experienced you are, the less the ovarian reserve loss. The less experienced you are, the bigger that loss. There's a great article from 2021, and I'm happy to email this to you like everything else. I'll give you my email address at the end of this lecture. Managing endometrioma to optimize future fertility. Endometriomas often occur in young patients. What do? The management of endometriomas in women wishing to preserve their fertility is complex. While surgery can help to achieve pregnancy in some, it may also have a detrimental effect on a woman's ovarian reserve. The present article reviews the impact of endometriomas on fertility. What's the bigger danger, the endometrioma or the surgery with regard to fertility? Experienced surgeons remove less healthy ovarian tissue at the time of ovarian cystectomy. The bad surgeon is always dangerous. And this is dangerous because endometrioma is often considered easy surgery. Endometriomas and trying to conceive, that's the situation. And again, basic messages in patients who are younger or older than 35 and the endometrioma is bigger and smaller than 4 centimeters. That's where you make a decision. Patient is older than 35 years old and the cyst is less than 4 centimeters. Go to IVF right away. Patient is less than 35 years old and the cyst is bigger than 4 centimeters. Go for surgery and see what happens. Again, happy to send you this presentation. If endometrioma surgery is performed, cystectomy by excisional surgery is the most effective way. Better than cyst drainage or ablation of the cyst, even though the literature here is evolving. Recurrence rate 16% to 50%, which already shows that the surgeon is the most important risk factor. Careful, repeat surgery is dangerous. Repeat surgery does not improve fertility outcomes. ART IVF is much better. So, in case of recurrence, don't do surgery again, but go to ART IVF if fertility is an issue. Let's talk about bilateral sacroiliac ligament involvement. If you don't have a hypogastric inferior, you don't have micturition. The hypogastric inferior runs exactly on the sacroiliac ligament. you can resect one side completely. Patient will still be able to function. If in severe endometriosis you resect both sacroiliac ligaments, then the patient will have to void her bladder with a catheter for the rest of her life. In a young patient, that's a big deal. So again, you have the ureter, you have the sacroiliac ligament, and this is where the hypogastricus runs. For most surgeons, nerve sparing means reduced radicality. Never forget, endometriosis is a self-limited disease that stops at around the age of 52, but life expectancy for women is 80 plus years. Be very careful not to harm a woman more than you help her by being too radical in your surgery. Shaving or segmental resection, that will depend on your GI surgeon. It's evolving and it would require a complete lecture to go through the literature. Nerve sparing surgery, it's a very complex subject, and again, it would be a different lecture. What are the key surgical questions you need to address when you're in the operating room? Number one, can you lateralize the ureters of the disease? This is one of the main issues, and again, the key thing here is you go at the endometriosis from the healthy tissue towards the non-healthy tissue. You start laterally, laterally, laterally. You never start close to the lesion or even within the lesion. Number two, can you dissect the endometriosis, the colorectum of the posterior uterus, the posterior vagina? Good question. This is the critical area. Number three, do you need to resect vagina, which always makes the surgery harder? Number four, can you dissect the endometriosis of the anterior wall of the colorectum? Or do you need segmental bowel resection? First, the first step is always to separate the rectum and the uterus. You normalize the anatomy. And I have a small movie. We'll see whether this movie will transport. If it does not, you're not missing much, because understanding about endometriosis is something that requires much more a systematic understanding of the disease than the actual technical knowledge. If you can't see this movie, which I'm not sure you will be able to, you will realize it's a classic endometriosis. And what's special about endometriosis, severe rectovaginal deep infiltrating endometriosis, is that there are no anatomical planes. They're completely destroyed, even more than in cancer. And you have to create your own planes using sharp dissection, using scissors, coagulation, or using a harmonic scalpel or any other energy source you could or might use. So in this case, if you can see it, we are using the harmonic scalpel, and we're trying to dissect off the endometriotic nodule that has fused the posterior wall of the vagina, the cervix, with the anterior wall of the rectum. Classical situation. In this situation, we've already dissected out the ureters left and right. We have distanced them from our central problem. Remember those points that you need to address. So you always start laterally, you always dissect out the ureters, you always distance them from the midline, and then you slowly take down the endometriosis in the midline. And what you try to do is you try to isolate the nodule on the rectum, on the rectosigmoidal portion, so that the pelvis is clear, and then you can address the issue of the remaining endometriosis on the rectum. How far do you dissect? Well, until you reach healthy tissue. Endometriosis is mostly just fibrous disease. You can see here how we are slowly reaching healthy tissue. And again, this will fall down on the rectosigmoid and then finally allow us to resect the tissue there, either through discoid excision or through segmental excision. It's knowing the anatomy as it should be that allows you to cut when that's the only option. Sometimes you just have to cut, as our teacher Arnaud Vattier so brilliantly says. And now, discoid resection, shaving, segmental colorectal resection. Again, that's another lecture. Be careful watching too radical surgery. You never get to see the post-operative course. It's easy to watch radical endometriosis surgery and then the endometriosis is gone. And it's brilliant what these guys can do and the technical skill behind it. But any true endometriosis surgeon would say more important is selecting the patients, talking with the patients prior to the surgery, making clear what risks there are, and making sure you're doing the right thing. You're treating the symptoms, not the disease. Colorectal endometriosis, resected if it is asymptomatic? Probably not. Leave it behind when you know you only get one shot. Difficult intraoperative decision making. And I'm happy to discuss these issues after the lecture. Always laparoscopy, never laparotomy. This is a chronic disease. If you start with a laparotomy in a 25-year-old patient, that's a disaster for this patient because she's going to have additional surgery and you can only do so many laparotomies, whereas you can do as many laparoscopies as you like. Integrated treatment again, 1 to 8 points. Start with medical treatment, diagnostic laparoscopy at some point, conservative treatment if possible, fertility treatment if desired, therapeutic laparoscopy focused on specific pain areas. If you do radical surgery, you better be skilled. Follow surgery always with conservative treatment or with pregnancy. The more pain, the more surgery. And finally, 10 Frankfurt key points, which I'm not going to repeat here, but again, I'm very happy to send you all this in my email, which is sven.becker@kgu.de. Excellent article also, the ESHRE guidelines on endometriosis. There's not a lot of evidence-based literature, but here experts came together and offered a very pragmatic approach. So if you want to see the most up-to-date information, take a look at the ESHRE guidelines 2022. Again, here's my email. I thank you very much. And I certainly hope I will be re-invited next year because I will definitely come to Cairo no matter what. Thank you very much.
Thank you very much. Professor Becker is with us online. If we have a couple of questions, Professor Nashar.
Thanks, Professor Becker. As regarding the first two principles of you, no diagnosis without laparoscopy and no treatment without diagnosis. These two principles against the recent guidelines of the ESHRE. According to the ESHRE guidelines, laparoscopy is not the golden method for diagnosis of endometriosis. Ultrasonography, transvaginal ultrasonography, and MRI is equivalent to laparoscopy regarding diagnosis of endometrioma and deep infiltrating endometrioma. Only for the superficial or the peritoneal endometriosis, laparoscopy is recommended. Second, you mentioned no treatment without diagnosis. Also, the guidelines of the ESHRE, we have to consider empirical treatment. That's to say, if we have pain, we can give contraceptive pills or progestogen, and if this pain relieved, we should suggest diagnosis of endometriosis.
Thank you. Can you hear me?
Yes.
Yes. First of all, thank you very much for inviting me to this meeting. I'm currently at the AGM meeting in Denver, and I want to say thank you for this excellent question. You are absolutely right, and it's for this reason that I included the ESHRE guidelines. 2 points. Clearly, you can make the diagnosis
Of an endometrioma on ultrasound, and a skilled sonographer can also assess deep infiltrating endometriosis. But remember that where we come from. We come from a situation where women often have pain for years before their problem is properly diagnosed. So the reason why I call for laparoscopy is twofold. Number one, I live in a country where it's very easy for me to obtain a diagnostic laparoscopy. And I appreciate that that's not the case everywhere. Number two, as long as you know, a lot of women have just dysmenorrhea and you never really know what's going on. This is why I personally believe that laparoscopy has an important part. But everything you've said is absolutely correct. And in my pragmatic approach, I would also recommend treatment on an empirical basis. But I believe that at some point, if you continue to have pain, the diagnosis should be made histologically. But thank you very much. Those are very, very good points, and I can only agree with you.
Thank you very much, Professor Becker, and we certainly would like to have you with us next year. Thank you very much.
Thank you.
Our next speaker is not strange to us, Professor Yaqub Khalaf. Professor Khalaf is professor in reproductive medicine and surgery, Guy's and St. Thomas Hospital, King's College, London, head of fertility service and director of assisted conception unit and center for pre-implantation genetic diagnosis. Professor Khalaf is going to speak to us about assisted reproductive technologies, where we are and where are we heading.
That's okay. Thank you very much, Professor Muhammad Yahya. And ladies and gentlemen, I'm glad that you are all here. I'm glad that I am with you, but I can't start without thanking Professor Surur and the organizing committee. Now, the topic or the title that I'm speaking about is rather ambitious. So I hope that I will fit in all I need to say with a bit of luck today. And I hope you get the message that there is a lot happening in our field, but you can say there is a lot that is not happening as well. And I hope that I will explore both of them. I promise we did the due diligence before coming to this podium, but there is always that bit of glitch with the IT. Didn't we? Yeah. Yeah. Okay, so I think I can go through a few of my slides because they are really more of picking up from where we left off. IVF, when it first started, the main concern was whether it will work. It was not whether it can be improved or it addressed safety. So much so that the first 100 attempts of IVF, when they presented by Patrick Steptoe and Bob Edward as the RCOG, the success rate was 4%. So they were excused to be focusing on whether it will work or not. And poor Louise Brown had a lot of x-rays to ensure that she is not born with 3 legs and 2 heads and everything else. So you can see how primitive things were at the beginning. But with progress, people turn to safety and turn to innovation. And that is my focus, not at the beginning, but as to move from will it works to how we can get it spread widely in the world, and no surprise that it is conducted everywhere as per this documentary in CNN. And you will see from the Human Fertilization and Embryology Authority that IVF cycles surpass 1 million and UK fertility treatment is more successful than ever. All is reassuring. You look at the Society for Assisted Reproduction Technology and you'll find that 73,000 babies born from assisted reproduction in 1 year. In actual fact, the previous year, even more. It is not an exaggeration to say there must be at least 10 million babies born as a result of IVF, and that must be an underestimate because people do it everywhere and they don't have any mechanism for reporting, so you can imagine the magnitude of assisted reproduction. Now, if I want to talk about advances, we have to focus on 2 categories of advances. One is the consolidation of what we do currently, and the second one is development of new and disruptive technologies. We cannot proceed without focusing on safety. And these are the 2 major complications. No matter how far we go, they will stay the same. The most important complication of assisted conception is multiple births and ovarian hyperstimulation. What have we done about them over the years? We have done a lot. Since we realized that the presence of IVF was synonymous with the presence of that pandemic of multiple births, whether it is twins or triplets. And for you to know that the rate of twins had increased by 60% and triplets by 430% thanks to assisted reproduction, and that was untenable. So responsible societies have to take action, and action they took. And that started by the One Child at a Time report that Peter Brody headed on behalf of many royal colleges and stakeholders in the process. And the best possible start to life was the aim to give the children resulting from IVF, and the campaign called One at a Time. And we contributed to this campaign and did workshop up and down the UK, and this seemed to have been helped by the availability of safe and effective extended embryo culture and blastocyst, because it gives people confidence to adopt the single embryo transfer policy. That would not have been possible without the improvement in cryopreservation, particularly vitrification. And after a few years of this campaign, you can see that the multiple births halved in a few years, because people agreed to the principle. You can put as many embryos as you like, as long as it is one at a time. And you can see here in 2019, the blue bars here on the side, they are the single embryo transfer. And in the United Kingdom, as of 2019, 75% of all embryo transfer procedures are involving single embryo transfer. I'm sure it is more now because it's 3 years since. And look at the result. The multiple births, which is mainly twins, has been reduced to just over 5%. I'm sure it is currently even less. And it did not reduce the success. If you look at the live births per single embryo transfer across the different age group, it has gone up over the years. A, because of the improvement in selection, and B, because of the resorting to the technology that is available. All of this would not have been enabled without the improvement in cryopreservation. And that made IVF treatment safer simply by dissociating the ovarian stimulation or dislocating ovarian stimulation from embryo transfer. And that is for the group at risk of ovarian hyperstimulation, and whenever it is thought appropriate in different indications for assisted reproduction. And it's been recognized that the number of freeze-all cycles in IVF continues to increase dramatically. I'd like to take this opportunity here to just warn against doing freeze-all when it is not indicated. Freeze-all is a safety measure. Freeze-all is not a measure to improve success in a patient who's poor responder or normal responder, just to get this across the board. And you can see over the years, fresh transfer is shrinking and frozen embryo transfer is increasing. And in the same process, the risk of hyperstimulation has been severely reduced. You look here in 2020, 2021, in the whole of the United Kingdom, with 75,000 cycles, there were 45 cases of severe ovarian hyperstimulation. And these are too many still, but there is significant improvement because it is now less than 1 in 1,000 when we lived with 3 or 5% for so long. What about IVF babies in general? What risk are they at? Because we don't really tend to remember that IVF pregnancy is associated with adverse consequences. And if you see here, the percentage of babies born under 2,500 grams is almost double what happens in spontaneous conception. The preterm births, the very low preterm births, which is under 32, is also higher in IVF babies compared with spontaneous conception. Small for gestational age. So all of these things, after accounting for multiple gestation, appear to be more with IVF. How about malformation? The absolute risk for singleton being born with a major malformation was 3.4 among assisted reproductive technology children and 2.9% among children spontaneously conceived. This is a large Scandinavian study with follow-up and proper ascertainment and proper follow-up. Moving on quickly because of the limit of time into what advances we are talking about it. And I'd like to describe them as work in progress. A huge amount of advance really in the scope of fertility is happening every day. But I'd like to highlight to you how they have been described. Reproductive technology, a fertile area for investment. And there is nothing wrong with investment. But when it gets into commercialization and making money at all costs, things turn sour. And I can go through the list of any innovation. You could always have an exit where it was exploited commercially or otherwise. I start by this slide from Professor Dunay, who is here in the front row, where was introducing the ovarian cryopreservation. And it sounds like a small step, but that has opened a new opportunity for all patients with cancer, at least, because without this, they will be either resigned to future without reproduction, or will be resigned to having assisted conception when they may not need it, because some of these patients could retain the opportunity to have their own children. I know there will be talks about this, so I am not dwelling on this, but this is an opportunity that was one of the big advances in our field. However, again, I take the opportunity, just because you can take cortex from the ovaries and you have cryopreservation, it's not the end. It has more to it to validate the survival, and what you do will pay dividends for the patient, and don't make it a commercial exercise. How about social egg freezing, where people have become more aware of the biological clock, and they wanted to stop? I don't think they can, that's a bit naive, but at least they try. And you see a lot of funny cartoons in Google talking about, let's stop rushing to find husband and start rushing to freeze our eggs. That is just a little bit of exaggeration, because you cannot really replace one thing or another. And those who are driven by protecting their career and going up the ladder, they can do the same. But there's always the element of exploitation underneath. How about the use of ART to prevent transmission of heritable diseases? We are all aware of the grotesque legacy of genetic disorders, because it can vary from sporadic early embryonic loss, recurrent pregnancy loss, anatomical abnormality, mental disability, name it. And now, thanks to technology, we have a way out, because to prevent transmission of heritable disease, we can opt for prenatal diagnosis, which will be followed by termination if the baby is affected, or use pre-implantation genetic testing, or in future, maybe we could use heritable human genome editing, as I will come to this later. But if we start with pre-implantation genetic diagnosis or testing, this is not done to screen for aneuploidy, as you might feel. Although aneuploidy is one of the indications, but it's done for much more serious issues than that. These are serious diseases, whether it is Huntington's disease or the cystic fibrosis, Duchenne muscular dystrophy, hemoglobinopathies, myotonic dystrophy, etc. These are debilitating diseases. And at Guy's and St. Thomas's, we have a spread of all cases. The majority of cases will be in the Huntington disease and cystic fibrosis, but still there is spinal muscular atrophy, there is cancer susceptibility genes, etc. And how it is being done, we do the ovarian stimulation. Ovarian hyperstimulation is being eliminated by using agonist trigger in these patients. Culture of blastocyst to blastocyst and biopsy, blastocyst vitrification, batch genetic testing, which is more efficient. We saw the blastocyst and single embryo transfer. How successful is it? In one group of monogenic disorders, not including chromosomal rearrangement, 82 couples had only one embryo available to transfer. They had 27% live birth rate. But when they had more than one embryo to transfer, they had 70% cumulative live birth rate. And the total for the group was 50%, 54% per couple reaching transfer, left the clinic with a baby. And it's always heartwarming to see parents who consider maybe future without children coming to celebrate their unaffected children following treatment at one of our PGT baby party. Mitochondrial diseases, they are not as popular, but they are extremely serious. This is a unique inheritance because it is inherited through mother, because it is a cytoplasm, and when it is inherited, it's 100%. There is no two ways about it. And its effect is far-reaching because it can affect any organ, just about any organ in the body. The heart, the eye, the liver, the kidney, the pancreas, name it. And the only way you can deal with this in a preventative measure is to replace the cytoplasm. So that is a so-called three-parent embryo. You get the cytoplasm from a donated egg, you remove the nuclear material from this, and then you use the nucleus from the mother who is having a chance of passing the abnormality into her offspring, and then create the right environment for the nucleus to grow. I am privileged to have been at the board of the HFA when we issued the first license in the world for mitochondrial disease prevention through cytoplasmic transfer, or called pronuclear transfer. And Newcastle University is the only center in the UK who has been granted this license because they did a huge amount of basic work, and they continue to do this to ensure the technique is safe. How about genome editing? We all know that most of the diseases that we deal with have some genetic background. So it is so appealing if you can edit this abnormality in the gene and correct that book, which is full of mistakes, life will be rosy. But that is the theory. I keep repeating that in theory, there should be no difference between theory and practice. But in practice, there is. And that's what we have come to appreciate. If you wanted to know more about the ups and downs of heritable genome editing, I recommend to use this recent review from Eli Adashi and his group, talking about the ethical consideration and the hurdles to clinical practice. In ideal world, we would not need to exclude embryos as we do with pre-implantation genetic diagnosis, because if we edit the sperm, if it carries the problem through the man, or if we edit the egg, if the problem is carried through the woman, then we don't have to exclude any embryos. All the ensuing embryos will be suitable for transfer. But the possibility of more edited, unaffected embryos at the start likely to be outweighed by the unknown and unintended effects of edit. Now we appreciate that when you try genome editing, A, you could suffer the risk of unintended editing. You could suffer the risk in double-strand genome editing of having aneuploidy through missing half chromosome or whole chromosome. So I'm afraid we have a long way of safety measures and safety studies before this can be put into practice. And the main issues with heritable genome editing is multi-generational risk. We don't know from generation to generation what will happen. The need for and the feasibility of long-term follow-up. Who will be doing that and what is the responsibility? Lack of consent by the affected child, because they could have been inflicted some damage rather than preventing disease. Changing public acceptance, because it is almost designer babies and what people call, and all the ethical issues that surround this outcome. So a large body of work will be needed to better understand the endogenous embryo repair machinery and increase the frequency of desired repeat outcome rather than undesired ones. How about stem cells? Because everybody is having their imagination focused on stem cell being the answer to everything. And currently in practice, some use them most of the time wrongly, I have to say. But here is the current state of affair. In mice, the whole cycle of producing egg and sperm has already been completed. That's not controversial for a number of years. Interestingly, the people who did that in Japan were PhD students of Azim Surani, who is a very accomplished scientist in the University of Cambridge, who is working on this front in human. And Azim Surani himself was a PhD student of Robert Edward, who introduced IVF to the world. So it is a closed circle. However, what it was achieved in mice is not achieved in human. And I hope you agree with me that we are not mice. Blastocyst development from a primate is the closest we have come. And that blastocyst development after in vitro fertilization of spermatid derived from normal non-human bright embryonic stem cell is published in Fertility and Sterility. And it is really still reason for caution, because we may not also the same as rhesus monkey, that's one. And the second one, what is being produced is spermatid-like. So we still have a long way to have some reassuring result. So what's next? We always improvise because there is opportunity for investment, as I mentioned earlier. So there is something called polygenic risk score, where the aim of which is to try to tackle chronic diseases, chronic heart disease, diabetes, all of that. And the idea is fanciful, Because if you can do genome sequencing and find the mutation that associated with these diseases and remove the embryos that carry those mutations and do the propensity risk score or whatever, then you could end up with a baby free of insulin-dependent diabetes, for instance. It's a great idea, but in practice, we know these chronic diseases have three components. One is lifestyle. People who are obese more likely to have chronic heart diseases. And the other one is the environment, what environment people live in. And the third one is a genetic factor. So that focuses on the genetics and run wild with this. So you cannot make a diagnosis based on one arm out of three. But you'll find in the media that there will be breaking news about the first baby resulting from polygenic risk score. And there is a company that have branches almost in every part of the country, which is too dangerous, really. But what we can say. The limitation for this technique, number one, is so expensive. Only multimillionaires will assume even entertaining. And B, it is demanding on the number of embryos that it can be turning into a method for contraception. And so on and so forth. So it is self-limiting, thank goodness for that. So I'm not going. How about genomics of infertility? One or two slides. I know I may have exceeded my time. If you look at this Nature review, you will find for male infertility, whether it is pre-testicular or post-testicular, there are always some genes involved. That involvement can be strongly associated in red or can be just moderate association in green. And these issues can be tackled later, perhaps with genome editing. So there is a future there, but it is not to say that we should tap into it without the necessary precautions. The same for female. Even embryo arrest that sometimes we don't have an explanation for. Immature eggs, despite everything we do, all has some genetic predisposition, and that is all being highlighted from genome sequencing. And I'm pleased to say that part of the genomic task force for the RCOG, we're trying to improve education in that area that people can ask the right question. So where next? It is clear that we can. But really, ethically, just because we can, it doesn't mean we should, because we can do all the weird and wonderful things, but without safety consideration, it will be counterproductive. Ladies and gentlemen, thank you very much for your patience with me. Our safety trajectory is reassuring. We have safer patients because hyperstimulation is less. We have less multiple pregnancy, we hope. Innovation is continuing, and future is promising. Remaining challenges. Equity of access. We talk about all this fancy stuff. There are people who can only dream because they don't have the money. And most of the time it's so expensive. Careful and responsible innovation. Just because it sounds like a good idea is not an indication to introduce it. And the worst thing that our field can do is to make today's science today's practice. There must be a gap between science and practice where evidence is assessed and assessed properly. I don't want to be controversial. Scientists should not be trusted with assessing the evidence. They can only be trusted with science. Assessing the evidence should be only trusted to people who know what they are doing and they have that epidemiological skills. Integration of evidence into practice is also a challenge because we all follow our own intuition, and aggressive commercialization is here to stay, I'm afraid. Thank you very much.
Thank you very much, Professor Khalaf. We have time for one comment or one question.
Professor Yaqub, me as a member of the Egyptian Medical Syndicate, I am saying for you, you are always alarming ethical, legal, religious aspect in the present, even in the future, inshallah, as regard to the ART advance and technology and advance. Yaqub, you are a star in the scientific field, and you are a beloved professor, and you are lighting EFSS every year. You are most welcome.
Thank you very much. Thank you. Yeah.
No comment?
I was just
Only
wondering
one.
for
Okay.
treating mitochondrial disease. I believe you were the first to do pro-nuclear transfer, I believe, into a normal.
You speak a
donor.
bit louder.
Sorry, I wasn't close enough to the microphone. For mitochondrial disease, I believe you at Newcastle were the first to do pro-nuclear transfer into a normal donor. What do you think about, that can be tricky, about doing a spindle transfer and then after that fertilizing the egg?
Yeah. I think both are used, but what is being licensed in the United Kingdom is the spindle, is the pro-nuclear transfer. But I know the spindle can be used. And I think there are other way also. The polar body can be entertained. So there are three ways of doing, of dealing with mitochondrial donation. I hope I got your question correct. Yeah, thank you. Yeah. There is a question there, I think, Dr. Omar. Yeah. Yeah.
Thank you, Professor Yaqub. I would like to ask about mitochondrial donation. From the ethical point of view, we are in a Muslim country. This does not cause any kind of, it's not the same like donation of sperms or donation of oocytes. The mitochondrial donation, you said that we use cytoplasm from donor to replace the cytoplasm of the oocyte to treat mitochondrial related disease. I'm questioning about the ethical aspect of this donation.
Thank you. I think you meant the religious, not the ethical. Yes. Yeah? I struggle with answering scientific questions. How about religious questions? If you wanted my knowledge, I know there will be about 2% of mitochondrial DNA or genes that will be in the donated cytoplasm. What is the repercussion of this? I leave it to Mufti. It's not me. Yeah, thank you. Yeah.
Thank you, Professor Kalav. So now we have to move to the next speaker. Ström from Sweden. He works in the Department of Obstetric and Gynecology at the Sahlgrenska University Hospital. And he is one of the pioneers and the more important specialists in the world concerning the uterine transplantation. So, Mats, you have 25 minutes for your lecture, uterine transplantation and update.
Okay, thank you for the introduction, and thanks for So I can just start. I will have my talk about uterus transplantation, and I hope I have a wonderful audience here of Egyptian specialists, and I hope this can be an occasion actually to convince some of you actually to go ahead in Egypt to do the first uterus transplantation, because Africa is still a continent where uterus transplantation has not been performed, and that should spread to Africa also. And I think Egypt, with your advances in ART, would be a very suitable country. And so please follow my story and hope that the results we and other groups show can actually convince you to start also here. So absolute uterine factory fertility is the goal, the group which should be treated by uterus transplantation, and this is 1 in 500 women. In the Swedish society, we have the option of adoption. Gestation surrogacy is also an option to get children, not in Sweden and not here and not in most parts of the world. And I think you're familiar with the causes of absolute uterine factor infertility is that you have no uterus after hysterectomy, and different causes are shown here, or by Rokitansky syndrome, that is that you're born without the uterus. And I want to emphasize the Rokitansky or MRKH syndrome because those are the majority of the patients that have been treated. These are patients with with Mullerian agenesis, no uterus, and missing also the upper part of the vagina. Or you can have absolute uterine factor infertility because of non-functioning uterus, because of severe adhesions, malformations, and so on. Of course, a lot of the malformations are not with infertility. And this AUFI should not be called AUFI. We can skip the A because it's not absolute now. We have a treatment, and that is uterus transplantation. So my story on uterus transplantation started actually in 1998. I was an ovarian researcher from the start, and in 1998 I was in Australia, and I met a patient with a cervical cancer stage 1B. I was going to do a radical hysterectomy with her, and she suggested to me, can't you do a uterus transplantation? My mother could be a donor. I was very disappointed at myself because I had never thought about the concept of uterus transplantation. And first I thought it was a little mad idea, but then when we started to think more, I said this could possibly be done. And I think it was that my background as an infertility researcher, and now I had become a gynecology surgeon, was that I could actually said, well, we can see if this is feasible or not. If you're only a fertility doctor, you would say it's impossible. If you're only a gynecologist, you would say, why should you care about fertility? We care about curing the patient. So my story started in 1998 with this idea, and then I came back to Sweden and we started a research project to see if this is feasible. This is, of course, not a life-saving transplantation. You cannot go ahead and do it in the human. You actually have to optimize the procedures in several animal species and see if it's possible to do. And we started with the small rodents, mouse and rats, for 4 or 5 years. We then went out to the large domestic species, the pig and the sheep, and then the baboon from about 2007. And in 2012, we do the first transplants. And importantly, this was ethically debatable in Sweden, so we had thorough ethics discussion before. And hopefully this is an evidence slide to you, but you have to do research because you have to optimize the procedure, and looking at surgery, how to detect rejection, what is suitable immunosuppression, and also what about pregnancy in an allogenic transplantation model. So what we did in all these animals, that we looked at all these things, and then we advanced it to get to baboons, which is a non-human primate species which is very close to the human. And the first ethical guidelines actually came 10 years after we started in 2009, and we had lived after those guidelines, and that is also, of course, implementing the importance of animal research, also including non-human primates, because this is not a life-saving transplantation, it is a quality of life enhancing transplantation or infertility treatment. And the clinical flow of uterus transplantation in a research setting and also later as a clinical procedure is that you would evaluate and screen the potential recipient. Most of the recipients have been MRKA patients and a live donor. And we went for the live donor concept, and the suitable live donor could be the mother or another relative, not too old but with proven pregnancies. And the evaluation is medical, imaging, and psychological. And then that would accept the couple by an independent multidisciplinary board. After that, you would do IVF to cryopreserve embryos. Now we're aiming about 8 embryos for possibly 2 children. And then you would do the uterus transplantation procedure. If you use a deceased donor, you would do a fast screening of the deceased donor, which would come in within 24 hours. And it's obvious for you a deceased donor would be a multi-organ donor, where you would take the heart, lung, and kidneys and liver, but also the uterus. And that would, of course, be without complicated surgery in a live donor. And then you would wait for some time to do embryo transfers, hope for a pregnancy delivered by cesarean section, and then you could go for 1 or 2 or 3 pregnancies possibly, and then you would do a hysterectomy. And you would, of course, need immunosuppression from uterus transplantation until you done a hysterectomy. So we started the first clinical trial in the world. There was one case done in Saudi Arabia in year 2000, a single case, which was it was ended with a graft failure. So we did 9 cases between September 2012 and 2013 in April. And it was important, was a case series, because only one case could be a failure. We were expecting some failures and some success. And the first patient we operated was actually a cervical cancer patient, as shown here, as the same which gave me the ID. She had cervical cancer at age 37, and now we were transplanting her with the mother's uterus at age 35. And as you're shown here, now she's got 2 beautiful children, a son and a daughter. And she was brave, and she accepted to be the first patient. I think it was because she had gone through major surgery before, the radical hysterectomy with lymph node dissections. So in our trial of 9 patients, we had 8 MRKH or Rokitansky, those born without the uterus, and we had this cervical cancer patient, I said, and age were between 27 and 38 years, and of course they were healthy and had low BMI. The donors, we said a mother would be suitable if she was still healthy, and not more than 1 cesarean section, otherwise other relatives or other family friends. We could accept postmenopausal donors, so 5 out of these 9 were actually postmenopausal. The oldest was 62 years. The youngest was a sister with 4 children. She was 37 years. And this is very much like a kidney donation, a live donor kidney. They would find their own donors in the family or in the close friendship. And the donor surgery is shown here. You're all familiar with. We don't take the fallopian tubes, not ovaries, only the uterus. We extend the arterial supply to include most of the internal iliac artery, only leaving 1 posterior branch. And we take 1 or 2 uterine veins on both sides, and including a segment of the internal iliac vein. And of course, the complicated thing here is to preserve the veins, but it's also, of course, to preserve the ureters, which is very close to both the veins and the arteries. This shows on just a dissection figure, you can see the large uterine vein on the right side going all the way down to the internal iliac vein. So the live donor surgery, we predicted this would take 3 to 6 hours, because it took 3.5 hours in the baboon, but it actually took 10 to 12 hours. And this is, of course, a very long time for elective surgery on a patient which does not have any direct benefit herself. We thought that would decrease, but as you can see, the 9 cases, it did not decrease by learning. But importantly, there was only one donor with a medical complication. She got a ureteric vaginal fistula, which then was repaired, and with a follow-up 4 and 5 years after the surgeries, all donors are in perfect medical condition. And after these 10 hours, we take the uterus out on the back table as you would do a kidney. You would flush it and decrease the temperature, and then you would have started to prepare the recipient. The recipient is also by laparotomy, a lower midline incision. You would clear the external iliacs and the vagina, and then the graft would come in. And you would do anastomosis, as shown here, end to side on the arteries and veins to the external iliacs on both sides. One anastomosis takes about 20 minutes. The gynecologists are doing most of the donor hysterectomy. The transplant surgeon are doing the anastomosis of the vessels, and a small part of the donor surgery just when we decide where to take the vessels. And then we attach the vagina and you fixate the uterus, and this takes about 4 to 6 hours. It's a lot easier procedure than a donor hysterectomy. And the photographs here shows the mother's uterus in her daughter, then born with an MRKH. And we used immunosuppression. This is the first protocol we used, and this is ATG, 2 doses, and then it's tacrolimus and MMF. Now we only use ASA instead of MMF, and then we lower the immunosuppression. This is, of course, because it's allogenic transplantation, so you need immunosuppression. If we get rejections, we would detect that by cervical biopsies, as shown here. We take biopsies every week to start with, and then every second week. And in the middle here, you can see there is inflammation on the ectocervix, and we treat with cortisone for 7 days, and then it reverses. So we had several rejection episodes, as shown here by the ARs. Like patient number 5 had 3 acute reactions during the first year, but all were reversed by corticosteroids. And also they were non-clinical, so they didn't have any clinical symptoms. They were only detected on our protocol biopsies. But some, like number 4 and 5, 6, had no reactions at all. So out of these 9, we actually had to remove 2 uterus, 2 graft failures, number 2 and number 9. Number 2 after 3.5 months because of infection inside the uterus and low perfusion of blood. And number 9 after thrombosis already after 4 to 5 days. So 7 out of the 9 went to the 12 months mark when we started to do embryo transfers. And of course, they got regular menstruations. And then we announced the first live birth in September 2014, so that was 8 years ago in the paper in Lancet. And this was our patient number 5, and she was in good condition. She came in to the hospital in week 31 plus 5 because of headache, and we detected a severe preeclampsia, and we did the C-section the next day. And this shows the uterus, and this shows the little child who was born, and the happy mothers. That child now is 8 years old, goes to school, perfect health, plays golf and goes skiing, and is a very nice child. So, but from this first cohort of 9 patients, 7 successful, we actually got 9 live births in totals, because 6 out of these 7 women with embryo transfers gave birth, and 3 of those gave birth twice, so they got 2 children. All children were healthy, and they were of normal weight for the gestational age when we did the cesarean sections. But we had 3 cases of preeclampsia, which is a caution, which can be related to that these patients had single kidneys. So if you look at the results of these 7 patients with embryo transfer attempts, actually we had a 100% cumulative clinical pregnancy rate because the 6 women delivered babies, and 1 woman, she had actually 6 pregnancies, but with miscarriages, some as late as week 17. And the clinical pregnancy rate is acceptable, 33% per ET. The live birth rate is low, it's 20%, but that is because that's single woman with 16 embryo transfers. And the take-home baby rate is good. These results, you should put that in the perspective of that this is was the first trial in the world that results will get better, so this by optimizing the procedures. I think it's also good to know that I heard that before the first IVF baby was born in 1978, there were more than 200 procedures done to try to achieve that pregnancy, and now we know how successful IVF is today. So what I'm saying here is that in the future the results will get better and better. And we of course look at the children. This just shows the growth trajectory up to 2 years in this first study, and they are all grow normal, and also behavioral tests are normal. So we started our second trial, which was a robotic uterus transplantation trial. We did a donor hysterectomy by robotic assistance. This is nothing which you would need, but this is possibly a technical advancement in the future. The thing was that we wanted to actually cut down the time of surgery from these 10 to 12 hours. We will have less tissue damage and of course lower the hospital, decrease the hospital stay. We published the 6-month outcome in a paper in fertility sterility. You can look at that in detail, and also the outcome of recipient surgery in the paper in Journal of Clinical Medicine. But we use Da Vinci dual console with 45 docking. We have 2 robotic surgeons, 3 arms to use, and we have 1 laparoscopic surgeon with 2 instruments, so actually 5 instruments to use. And then we follow the step-by-step surgical development. We first do the bladder, then we identify the ureter, we dissect the arteries and veins, and then we do the very difficult ureteric tunnel and the frontal aspect of the ureter. But this is described in the fertility sterility paper. So the interim results, because this is still ongoing, is that 6 out of these 8 were surgically successful, because here also we had to remove 2 graft failures because of they had blood perfusion and so on, but the blood perfusion was too low, and we did not get any spontaneous or HRT-induced menstruations, because we could possibly had irreversible endometrial damage. We have 3 that have delivered babies, and we have 2 ongoing pregnancies for second baby, and we have 3 that do further embryo transfer attempts. Some of those have been pregnant but had miscarriages. And my hope is that 5 or hopefully 6 out of these 6 will end up with live births. But it's a long time from surgery until we end the trial. And what we're not the only country that have done robot hysterectomy robotics, but also done in some other countries as listed here. And what we can see is that we improve the dissection, we get less blood loss, we shorten the hospital stay, we shorten the sick leave, but there is still a very long surgical time. It still takes 10 to 12 hours, so we have not been able to shorten that so far. So we started last year, which we think is the first one in the world. It's a total robotic uterus transplantation. That means that you would do the donor hysterectomy robotically, remove the uterus through the vagina, and then also do the transplantation in the recipient by robotic surgery. And we don't, when we open the abdomen for a short while when we place the uterus into the recipient, because we don't dare to put the uterus in through the vagina. And then we close this with a gel port, but all the surgery is done by the robot. And here you can see the uterus coming in the B, and then you can see the venous anastomosis and C and D, arterial anastomosis in E and F, and this is done robotically with the Gore-Tex sutures, and then we do the vaginal anastomosis. So the first one we did started with menstruation after 1.5 months. She has had no rejection, and she got pregnant on her second embryo transfer attempt, and she is now an ongoing pregnancy about 12 weeks, and of course we will publish this when we have a live birth. The time of the recipient surgery was longer than 4 to 5 hours than in open surgery. And I still want to emphasize this is not something which should be done when you start a program. You start a program by the classical laparotomy approach. So what are the worldwide activities so far? Well, I said about more than 80, but it's actually more than 90 procedures have been performed. And the countries are listed here. The first one was in Saudi Arabia, but they were not successful. And then you've seen all the countries that have done cases. Not all are successful, but you can see also on the map here that most cases are in Sweden and in the United States, and there is no center at all which have tried this in Africa. So I put Egypt on the list here, possibly to start from 2023 and to 24. And of course, if you would need our assistance, we would be happy to help, because that's the way we work, to transfer the technology in a very systematic way. And this is not a technology where you can just go and have a look at surgery and go home to do it. It's a long-term transition of knowledge. And the number of babies are now more than 40 worldwide, and I've listed here the countries with babies so far. In the beginning, we could publish case series and case reports on uterus transplantation. That is not possible because this is nothing novel in uterus transplantation in a new center. So the most important tool we have is the registry of the International Society of Uterus Transplantation, which actually collects information worldwide on all the activities, both failures and successful transplantations, but not identifying any single centers. So we have been able to get all the cases in the world except the cases in the United States and India, but we think we will get the US cases also in the next registry report. And ISUTX is a society which is a part of Transplantation Society. And here you can, if you are interested, you can read in that paper, but here you can see that if you look at the number of cases, the maximum number of cases, 12 was done in 2017, and then it has decreased somewhat because of the COVID. In the beginning, most were done by, the majority, 30 of these 45 cases are done by live donors, and the majority was first in the laparotomy, but now robotics has entered the scene. And also you can get information on surgical durations. You can see here that the surgical duration couldn't be up to 14 hours, but actually in some places they have been able to reduce it, not to 4, but to 6 hours in live donors, so that is promising. The duration of recipient surgery is about 4 to 6 hours. But there are a lot more details in these papers if you are interested. So the total surgical success in the registry report is 71%, more for robotic, but that is possibly because those robotic teams, including ours, have first been practicing by laparotomy and then they have transferred to robotics. I would say today, for new centers, the surgical success, when surgery is successful, you get restored menstruations and a good blood flow. is more than 85%, and the live birth rate today after a successful uterus transplantation is more than 85%. So that means this is a very, if you're just, you master the surgery, you're good at selecting your donors and recipients, and you are good at IVF, you can actually tell the patient you have 85% chance to get a good uterus, and if you get a good uterus inside you, you have 85% chance of getting one or more children. And that is a very effective infertility treatment. But it's a complicated infertility treatment, and it's also costly. And in the registry report, the live birth rate was 40% per blastocyst, and for day 2, 27-28%. The gestation length of these births were 35 weeks, but that is because we started to do elective cesarean section at 35 weeks. Now it's increased to 37 weeks. So my conclusion is that uterus transplantation has repeatedly proven to be an effective infertility treatment for UFI. There are developments with robotics, and it will possibly in the future increase the safety and efficacy. But when you start a program, don't use robotics, use the classical laparotomy technique. And it's now in the transition from an experimental to clinical procedure in some countries. It's offered commercially at one center in the United States. In Germany, it's approved as a clinical procedure. And in Sweden and Czech Republic, we are in the process of accepting as a clinical procedure. And if it's accepted in Sweden, that means this is a procedure which a patient can get for no costs, the same as IVF if they qualify. And also I want to emphasize the registry is our most important research tool to increase the safety and efficacy of this procedure. So if you start new programs, please register the new cases prospectively into this registry. And I will thank you for listening, and I was to emphasize that we have actually done a very big work with research and to develop the surgery. But I think the biggest achievement by me is possibly not that, it's actually to create a team, because this is a team effort. Not only one very important transplant surgeon or one gynecologist could never be done. You have to have a team, a multidisciplinary team of doctors, and nurses are possibly equally important. So when you think about this, create your team, start to discuss it within the team, and understand what will be your role in this procedure. And if you want to read more, there is one book covering everything from research to clinical procedures by Springer, and there's also the web page for ISUTX, which is on the Transplantation Society. Thank you very much for attention.
Thank you very much for a very beautiful presentation. May I just draw your attention that in Egypt there are a lot of ethical and religious legislation that needs to be addressed before we even start thinking about doing any uterine transplantation. Maybe the transplantation itself is surgical, but the process of having a baby of another mother inside the womb.
I'm aware of that, and it's it was the same in Japan with other religions, and they took them 10 years to get an ethical permission and so on. So but it should start to be discussed and so on. And of course, when you start in any new center, you don't start as a clinical procedure. You have should be as a registered clinical trial under a research protocol, and with adding your data to the registry, and also possibly publish the papers.
Yes, please. Professor, yes.
Well, first, congratulations. I think I first met you in Valencia maybe 2 decades ago when you were starting to do this, and you planned it out so methodically with animals first. You're really to be congratulated. I just have 3 simple questions. Your immunosuppression protocol, because it's very safe. How important is the HLA typing? And what is the relative sensitivity to rejection of uterus compared to heart or liver or kidney?
First, a comment of the immunosuppression protocol. It's like a standard immunosuppressive protocol which is used in kidney and heart. But this was the protocol we used in the first study. We actually lowered the immunosuppression in our second study because they may have some side effects. We have possibly a little higher rejection rate than they would have in kidneys and so on. But you know, the rejections are detected very early, and there's not any organ in the world that has been lost to rejection. They've always been able to reverse the rejection. So we're not worried about the rejections. We just have to detect it early until we don't get any damage. And of course, the advantage of the uterus is that we take a biopsy from the ectocervix, so we have availability of detecting rejection. If in a kidney you have to take an invasive kidney biopsy, or in the heart you have to take an invasive biopsy, so we possibly also over-treat some rejections, because it may be that they could actually spontaneously heal by themselves.
Thank you very much. Our next speaker is Professor Marie Madeleine Dolma from Belgium. She's the head of Gynecological Research Laboratory at the Université Catholique de Leuven in Brussels since 2012, and Chief de Clinique at the Clinique Universitat Saint-Luc, Brussels, Belgium. She's going to address the recent challenges in fertility preservation for cancer women. Please.
Thank you. So first of all, I want to thank Professor Serroux for the invitation and his welcome. And now, ladies and gentlemen, I will have the difficult task to keep you awake before the pause. So I hope you will enjoy and learn new things. So why do we need to preserve fertility in cancer women? Well, they receive chemotherapy, and we know that chemotherapy is ovarian damaging. Through different mechanisms, the loss of primordial follicles and also the loss of antral follicles. So what shall we do and propose to our patients? Well, we can propose to aspirate immature oocytes, and we can propose to aspirate mature oocytes. So this is done for malignant disease in patients who have time for 2 weeks of ovarian stimulation. And it is an effective option. Like you see here, oocyte vitrification is used as an efficient option for elective fertility preservation. I want to insist on an important message from the team of Anna Kobo that you see here. And you see that there are 2 groups. In blue here, you have the young patients, less than 35 years of age, and in green, you have the older patients of 36 or more. And you see, if we take the young patients, let's say, for instance, 8 oocytes, we have here 8 oocytes, it will give 40% of cumulative live birth rate. So 8, we go up, we are 40%. But with the same number of oocytes in a patient of 36 or more, 8 oocytes, we don't have 40% of cumulative live birth rate, but 20%. So age is really an important factor. And they tried to do the same graph in cancer patients, so it is also effective. We have that same limit of age with the success rate. Okay, but we have another limitation for oncofertility, which is the number of cycles that you can offer to these patients. Of course, they have time for only one cycle, and if you do it for social reason, you can come 2 or 3 times. So they are limited by the total number of oocytes that will be frozen. For patients with malignant disease, we can also freeze ovarian tissue. That is an indication for prepubertal patients and patients who require immediate chemotherapy. They don't have these 2 weeks. First, when we cryopreserve ovarian tissue, it is possible from a technical point of view to aspirate immature oocytes from the tissue. And there are already some live births described with the technique. But we need to insist that at present, in vitro maturation of oocytes recovered from these follicles is not a stand-alone technique, so it can be proposed, but not only. And so we go on. If we have frozen tissue, a patient will come back for orthotopic transplantation. Here you see the technique. The atrophic ovary is peeled, and the atrophic cortex is replaced by these frozen toad fragments. We do not stitch all these 2 small pieces, but we cover them with an interseed. And if the patient has no ovaries left, you can always transplant into a peritoneal pocket in a place where you have good vascularization. Good, the patient is transplanted. How long shall we wait until she has recovery of her spontaneous menses? In all cases, there is restoration of endocrine function, so it works from that point of view in 100% of the patients. But after 4 months, you see here, it takes 4 months from the transplantation before we have the rise in estradiol and the drop in FSH. How long will it work? Well, it does work quite a long time, even though we have only 5 or 6 little fragments. You see here in these 5 patients who were young at the time of cryopreservation, less than 22 years of age, well, easily 5 to 7 years of ovarian function are there thanks to the graft. And of course, you can graft the patient twice if you have enough tissue. And you see here the first case, she was still menstruating after 11 years. So the endocrine point of view is working. But now, the reproductive point of view, that is important for our cancer patients. And how many babies are born so far? You see here, little Tamara. This was 18 years ago. This was a publication in The Lancet, 2004. So she came back to our medical department after 18 years. Good, but since then, how many babies are born with the technique? So let's do the exercise together. And since 2004, you see Tamara here, the publication. Then we have the publication of Dromerov in Israel with the second baby, Isabelle de Meserer with the third baby. And if we do that exercise, thanks to PubMed, you see, that it's an exponential increase. And this is the last publication of 2020. There were 200 babies born. So now, 2022, we have more than 200 babies. And we can say it works thanks to the slow freezing technique for all these babies, all but 2. This was with vitrification in Japan. The technique of transplanting to the ovarian medulla or the peritoneal window, they both work equally well. And patients are pregnant after IVF or spontaneous. Of course, it depends also on the sperm parameters and the quality of the tubes. So what about the pregnancy and live birth rate? It is good to say there are 300 babies, but finally, if you have done 3,000 transplantations, it's another matter of success. So how shall we calculate the live birth rate? So it was not easy, because if you have negative results, you don't publish them. So we put our results together from Israel with Shapira and Merov, from Brussels and from USA with Sherman Silber. And you see here only the frozen toad patients, well, frozen total ovarian tissue transplanted in 32 patients, 23 patients and 5 patients. So in total, this is a series of 60 patients transplanted with frozen total ovarian tissue. You see that 30 of them was pregnant and that 41.6% had at least one live birth. Because if it works, well, the patient can have more babies than one. And there are patients with 3 or 4 babies. Going on with the same willing of having good results, well, having a clear topic of the live birth rate, we put the results of 5 leading European centers together. This was 285 transplanted patients. So we have the results of Belgium, from Germany, France, Spain, and Denmark. We will see together the live birth rate of that paper, natural conception versus IVF, the graft lifespan, and also the effect of previous chemotherapy and previous radiotherapy. So, as I said, we had together 285 transplanted women, 176 conceived naturally, and 109 trying to conceive after IVF. So the percentage of conception was 40% in the natural conception group and 36% in the IVF group. Live birth rate was 30% and 21%. If we have a close look onto the IVF patients, you recognize here 109. Well, the difficult step is to obtain embryos, because as you see here, only 50% of the patients after transplantation and IVF on grafted tissue will have embryos to transfer. But once you have embryos, it works really well, because then a relatively large proportion of those who did undergo embryo transfer conceived, as you see here, 72%, and 43% gave birth. What about the age? Well, it's not difficult to understand that the age at ovarian tissue cryopreservation is the most important. And if we calculate the mean age in the group of patients who did give birth, it was 26.9, and the mean age in the patient who did not give birth was 30 years. What about the graft lifespan? So the ovarian function longevity after grafting of these small pieces of ovarian tissue. You see here that at 5 years, we have 55% of the patients who still have a graft survival. So more than half of the patients will still have spontaneous menses thanks to the graft. And of course, as we said, the younger the age at cryopreservation, the longer the graft survival will be. Another interesting result is about chemotherapy. So we collected the information about the history of chemotherapy before ovarian tissue cryopreservation. This is usually the case for some acute leukemia, for instance, where the oncologic hematologist will not wait to send the patient to a fertility preservation program and so on. That patient will often receive chemotherapy immediately. And so later on, she will be sent to the gynecologist. And so we had there 50 patients, as you can see here, who received some chemotherapy before freezing their ovarian tissue. And in the other group, 221 who did not receive chemo before freezing. And you see that the one who received chemo, they had a percentage of women giving birth of 44% and 20% without chemo. So the message here is that these patients who had received already some chemotherapy, well, you still can accept them in your fertility preservation program. But what about irradiation? In our series of 285 patients with ovarian tissue transplantation, 36 patients received some kind of pelvic irradiation. It is important to see which kind of irradiation. Here you have the group of high doses of pelvic irradiation. This is the case in cervical cancer and anal cancer. We had there 15 patients, and none of them became pregnant. So they all had ovarian tissue transplanted, but 0% of live birth rate. You have the reduced dose, which is the case in colorectal cancer, 8 patients, 1 had a baby. And then the low dose of pelvic irradiation, 10 patients with lymphoma, leukemia, sickle cell disease, and 50% of them had a baby. So probably the explanation of that is that the pelvic environment after high dose of irradiation is not a good site for ovarian tissue transplantation. So this obliges us to consider other areas for transplantation, like extrapelvic, outside the area of irradiation. So the message of this article is that it is the most important published series. 3 out of 10 grafted women will have at least 1 baby. Some previous chemo is not a contraindication to freeze ovarian tissue, and pelvic irradiation can be harmful, and we need to see which doses was given to the pelvis. What about the future? So it is still a challenge to freeze and transplant ovarian tissue, and we have 3 main options for looking into it for research. One important option is how to prevent chemo-induced gonadotoxicity. If we can have chemotherapy that will not damage the ovary, will be the best option for our patients, I believe. Second option, how to improve the results of ovarian tissue freezing and grafting. Therefore, we have in the lab ongoing trials with adipose tissue-derived stem cells, and the aim is to boost revascularization, because we lose a lot of follicles immediately after the grafting. And I believe a third option is how to make a successful in vitro growth of immature follicles or the artificial ovary. So while significant progress has been made and continues to be made, still there are numerous challenges, but science is slowly but surely delivering the answers we need. For those who are interested, we organize in January a workshop on freezing and transplantation in Brussels. So I would like to thank my team and thank you for your attention.
Thank you very much for very interesting results, actually. Any questions?
Thank you very much for this elegant presentation. Actually, I remember the first meeting in Brussels in year 2010, in December, with Professor Donnet. And at that time, the number of babies delivered by tissue freezing was about 7 or something like that, and now it is more than 200. Do you think that the growth is slowly? Now it is more than 12 years.
Yes.
So I think that the growth should be more than that. This is the first question. The second one, what about the recurrence of the malignancy? Any cases of recurrence of the malignancy, especially the lymphoma and the other thing?
Okay, so about malignancy, indeed, in the study, it was studied also, and the patients who had recurrence were mainly breast cancer patients, and what we know is that these patients, well, they remain cured cancer patients, so we still need to continue to keep in mind that they had a cancer, okay, they are cured, they can come for a baby, they can be transplanted, but we need to keep in mind that we need to check that. And all the relapse were due to the cancer itself and not to the tissue, because we could say it from the place of relapse. It was cutaneous relapse, you know, for instance, after breast cancer. And one patient with sarcoma, they could screen all the tissue that was left, and the tissue was negative for sarcoma cells, but the patient had a relapse of her disease. So it's important to bear in mind these patients remain cancer patients, indeed. Thank you. What about the, well, in fact, what do you think? It's not good enough or it is?
It depends on the utilization rate. What's the utilization rate of cryopreserved ovaries?
The utilization rate is less than 10%, is around 5-9%, something like that. That's true. But still, we have prepubertal patients, so of course they will not come back before another 15 years probably. So slowly maybe we can see a slight increase in the use of the tissue frozen.
I think you should organize more workshops outside Belgium and everywhere.
Okay.
Yes, please.
Thank you, Professor. If a young girl or a young lady is to undergo chemotherapy, would you offer her oocyte freezing or ovarian tissue cryopreservation?
Okay, so the question is if she had already received some chemo or before?
No, she is to receive.
She is to receive. So before chemotherapy, you can offer both. I think it will probably depend of the emergency of the start of the chemo. If she has no time, because it happens with big masses in lymphoma patients, well then the only option you have is ovarian tissue. If it's a breast cancer, she can have breast surgery and then stimulation to freeze oocytes and then have her chemo 6 weeks later. So that's not, it's a very different situation according to the type of cancer.
So if she has time, oocyte cryopreservation
yes.
is more useful or more beneficial to her?
Well, it's...
in the current practice?
It depends on your settings also, and just bear in mind that you have only one chance of stimulation. So if you have 5 and then she starts her chemo, I hope they will survive. I hope these eggs will be fertilized and will, you see. Sometimes you can propose the 2 techniques. It depends also on the financial situation.
Thank you.
Professor Selber.
That was an excellent summary, and it seems like the only poor results were with strong pelvic radiation, and so with those cases, would you advocate? Do you think it's from the poor bed that you put the tissue in, or is it just you think the uterine receptivity is the problem, and should you consider doing IVF with them with a gestational surrogate?
Thank you. That's a good question. So after irradiation, it is both, but it is mainly the area, the receptive area for the transplanted tissue that is not good. Because we transplanted on a transposed ovary, which was outside the field of irradiation, both together in the same patients, in the pelvis and on the tube that was transposed. She never had any follicular development in the pelvis, but on the tube outside there, she was ovulating every month. And so she was menstruating. The other question is the uterus after irradiation. Well, these 0 pregnant patients, many of them had uterine hysterectomies, in fact, because for cervical cancer. So it was the first step to have embryos. That was already the problem, because they were anyway going to have surrogacy mother. So I really believe it's the area of transplantation that is key to the success of the transplantation. Thank you.
Thank you very much.
Thank you.
We are coming to close this session, and please don't leave. We are going to start the next session immediately.
الناس عايزه تخرج على البيت. خرج عشان سيمبوزيوم. ستارت. يلا عشان احنا بين الساعه 3. لا عاوزين نوفو. We'll start now this session for company Novo Nordisk company. This session about obesity on women health. First speaker, Professor Dr. Hussam Fahim, Professor of Obstetrics and Gynecology at Al-Azhar University. He is the head of the Department of Obstetrics and Gynecology in Al-Azhar University, Cairo. One of the eminent professors in the field of obstetrics and gynecology. His talk about impact of obesity on women health. Please, Professor Dr. Hussam.
Thank you, sir.
Excuse me.
Yeah, Bismillah ar-Rahman ar-Rahim. If you'd like to take seats, please. Bismillah ar-Rahman ar-Rahim. Good afternoon, ladies and gentlemen. Again, on behalf of the board of the EFSS, I'd like to welcome you again in our distinguished meeting. And it's always an honor to be with you here every year. And we're really delighted to have such a big number in our meeting. Now, maybe I'll start my talk with how sorry we all felt, and I'm sure most of the people in the room here have lost dear ones, beloved ones, to the terrible COVID-19, me personally included. I lost a couple of family members as well as a few friends. But if you think of COVID-19, it's as innocent as a dove if you compare it to obesity. Well, so far, about 6 million lives have been lost due to COVID-19. Obesity does this in just 2.5 years. Every 2.5 years, because of obesity, the world loses 6 million lives as well. So it is actually much worse than COVID-19, let alone other diseases. We always take it lightly. It should not be taken that lightly at all. There are very few diseases that attack us on multiple levels, but I think none of them is as bad as obesity. It attacks basically all systems, and in each and every system it attacks on multiple levels, such multiple levels. I can't really compare anything regarding gynecology and obstetrics, and especially infertility, that could be as bad as endometriosis. We know that endometriosis attacks us on infertility on multiple levels. However, obesity is even worse. So it does attack on many levels, and I explain this in a minute. So basically, obesity is definitely a global epidemic, so we can call it a real pandemic. It does have effect on polycystic ovary syndrome, and I'm sure we're all aware of this, on fertility, pregnancy, menopause, and even cancer. This is one of the slides that I really hate. This is the incidence of obesity in the world. The darker it gets, the worse it is. And as you can see, our area, our region here, the Middle East, sorry, there's no pointer. The area of the Middle East, including Egypt and obviously the United States, are the darkest. The darkest in prognosis, darkest in incidence. We are one of the worst areas that have been hit by obesity. Maybe we're not aware of the statistics, but unfortunately it's a fact. This is a very simple list. Oh, thank you, sir. This is a very simple and actually short list of what obesity can do regarding gynecology. So, for example, it causes an early onset of puberty, which is something bad, not good, because it is associated with many diseases. Polycystic ovary syndrome, of course, goes without saying. We heard a lot today in the morning, especially on the first session, how a PCO can affect people regarding fertility, quality of life. And we all know that obesity has a direct impact on the incidence of polycystic ovarian syndrome. Anovulatory infertility, yes, the main cause of PCO, and therefore, obviously, it's increased by obesity. Fertility treatment. In the field of IVF, we are all aware that the worst patient that we don't like to show in the clinic is the one who is really overweight or obese. It's a challenge on every level. And regardless of this list, actually, things that cannot be written in lists, who would like to have a real obese woman with a BMI of 45 for embryo transfer? Can you actually reach the cervix with the cascospeculum? Extremely difficult. Can you get assistant to see the endometrial line via transabdominal ultrasound? Almost impossible. So there are even more things that are not written in lists. And these are the things that really affect us. And remember in the UK when they were talking about obesity, the simplest thing that they mentioned to us is, can you actually measure her blood pressure accurately? Do you have a cuff good enough to measure blood pressure? Do you like doing cesarean section on her? And all these things are not put in lists. But just lists include so many things. Early pregnancy loss, yes, of course, it's increased. Contraception, safety is really bad, and efficiency is really bad as well. So even if someone gets pregnant, doesn't have any gynecological problems, again, obesity starts to attack on another level, like, for example, pregnancy. And it's basic teaching that we know that gestation, diabetes, hypertension, and preeclampsia, instance of cesarean section, failure to go into labor and even be able to induce labor is definitely also worse in obese patients. Okay, what if we're successful and we got a baby, a good baby out of the pregnancy? Again, obesity can attack us again. Spina bifida is increased, surprisingly. Microsomia and macrosomia. Had trauma because of mechanical difficulty during delivery. Shoulder dystocia, our nightmare. You can expect it when you see the patient on labor ward. You know that this patient which is coming onto you on the labor ward, that you're probably getting a shoulder dystocia in this patient, and unfortunately it is unpreventable. And because of the maneuvers that are done before, because of that, brachial plexus lesions and fractures of clavicle actually happen a lot in these type of patients. So does weight gain improve the condition? Well, it's yes and no. There are things that sometimes are reversible. However, there are other things that are not. But the good news is most of these conditions are reversible by losing weight. For example, even non-gynecological things like decreased severity of sleep apnea. And I remember the first mortality I've ever seen as a house officer was a Pickwickian syndrome lady because of sleep apnea. She was something like 250 kilograms, and she actually stopped breathing while she was sleeping. And this was the ever first mortality that I saw as a mashru' doctor. There's even lowered risk of breast cancer in such patients once they lose weight. PCOS gets better and can, even if the patient loses weight in time, before puberty, around puberty, you can altogether prevent the incidence or the happening of polycystic ovarian syndrome. Some gynecological cancers, especially endometrial carcinoma, decreases in risk, besides many others. What about fertility? Well, let's start with PCOS. We all know that how PCOS happens is very complex. We don't know one single cause of PCOS, but what we cannot argue that obesity is one very important cause because of PCOS. We heard today again in the morning what PCOS is about, and it's possible that the future will tell us that PCOS is not just a single disease, but the most prevalent phenotype is the classic obese patient. Probably because of the insulin resistance and the hormonal imbalance that they suffer from. I'm not going to lecture you on the characteristics of the disease. I'm sure that you all know this by heart, but of course, anovulation and infertility are among the most important ones. Right, so PCOS, whether it happens in obese or non-obese patients, it is known to be associated with an increased risk of gestational diabetes and preeclampsia. So, obesity attacks us here on two levels, by causing PCOS and by a direct effect on these outcomes in any woman. So, is the solution weight loss? Well, in PCOS, it probably is. Once you lose weight, if you're suffering from PCOS, most, if not all, of the aspects of the disease do improve. For example, the insulin levels are lowered because of decreased or better improved insulin resistance. Decreased androgen levels, yes, this happens. And as you know, that the high androgen levels are causative or the complaint of most of the skin lesions or complaints in such women like hirsutism, oily skin, and acne. The periods start to get regular, and obviously there's improved psychological outcome by losing the weight per se, and by getting more regular periods, and hopefully by achieving a pregnancy as well. And of course, the cardiovascular symptoms and signs do get better. What about androgens? Do they decrease when you have your weight loss? Absolutely, and this goes without saying. There are several studies that have actually addressed this issue, and very simply, some of the studies, they measured free testosterone and sex hormone binding globulin before such patients died, they go on diet, and afterwards. And it was very significant that free testosterone is lowered and sex hormone binding globulin increases, and this is what we aim at, because it's the free proportion of testosterone that we don't like and is responsible about a major part of the disease. The same happens with fasting insulin. It is clear that fasting insulin decreases, and fasting insulin, when it decreases, this is a sign that insulin resistance is getting better with all its consequences. Oral glucose tolerance test, all the parameters and all the measurements in oral glucose tolerance test simply improve by mere losing weight without any other medications. Okay, what about the pregnancy? What does happen in pregnancy? Well, obesity is, as we know, increased by reduced infertility and therefore delay in pregnancy. And I think this list is even more than what happens with endometriosis. For example, one of the surprising things that I discovered by reading this article is that even early follicular atresia happens in obese patients more than other patients. There's increased aneuploidy, and I have no idea why. But it's been proven that aneuploid rate is increased in obese patients as compared to normal patients with BMI. There is delayed meiotic maturation and increased follicular apoptosis. So even on the biologic levels, not just on the clinical levels, there seems to be much worse outcomes in such patients. Gonadotropin use is more difficult? Absolutely. It's the theory of a spoon of sugar in a small cup of tea or a spoon of sugar on a big cup of tea. So a normal patient that might need 3 ampoules for induction IVF, for the patient with the same parameters but just with the double of weight, you need the double dose to be able to get the same number of follicles. Pregnancy, maternal complications, it is basic teaching that we teach our students that gestational diabetes, hypertension, preeclampsia, venous thromboembolism all increase in obese patients when they get pregnant, but also because of pregnancy, the burden of pregnancy, and in conjunction with the burden of very high BMI, obstructive sleep apnea is quadrupled in such patients. Very simple things, again, that are not put on lists. For example, backache. We have seen patients who are obese and they're pregnancy and they're suffering with really bad backache, and we can't really do much about it because pregnancy is not the best time to lose weight. During birth, risk of cesarean section, the rising rate of cesarean section, failed trial of labor, and uterine rupture as well because of the abnormal mechanics of labor and delivery. Even the offspring are not immune from the attack of obesity. There is increase in structural birth defects, as I elaborated earlier, macrosomia and microsomia, and prematurity. And as we all know, because of the increased insulin resistance, and these women, their babies suffer hypoglycemia, and quite often they are actually admitted to the special care baby unit or even intensive care baby unit because of the hypoglycemia. Incidence of stillbirth is really higher, and neonatal intensive care admission. So again, another question. If such patients lose weight prior to embarking on pregnancy, does this have an impact on offspring? Yes, and it is all across the board. Most of the complications that we mentioned that increase during pregnancy are actually markedly reduced once this patient loses weight. However, this should be advised to happen before pregnancy, because combining dieting or medications or bariatric surgery with pregnancy is almost non-existent. Menopause, is it even worse? Yes. Well, the problem with menopause is that menopausal women, they have a tendency to put on weight, basically because of non-modifiable reasons, but also because of modifiable reasons. Some of the non-modifiable reasons is we can tell that each and every one of us gains half a kilogram or 1 kilogram the older we get. Nature, such is life. It happens to every one of us. So aging aids increasing the increase of weight, the hormonal imbalance, especially because of the lack of estrogen or deficiency of estrogen. Their satiety is changed and their energy expenditure is they don't do much, and therefore their caloric needs is less. They don't spend as much, so the extra calories they just accumulate in the form of fat and obesity. However, there are some modifiable situations or causes of such obesity, as for example, sedentary lifestyle. We consider that someone, if she's menopausal and it's time to sit at home, this is absolutely wrong. This is the time to start exercising and to increase exercising if you already started. What about cancer? Again, this slide was a surprise to me. Almost all studied cancers were increased due to obesity. Some of them increased by 700-fold. Some of them, like the ones we're interested in, breast, corpus luteal, and ovary, increased by between 50% and 30%. So even cancers in the general health for such patients is increased. So, as I've been telling you, it is a pandemic that's causing lots and lots of mortality on each and every level. So, ladies and gentlemen, to sum up, I believe that we should not just fight COVID-19 as a pandemic. There are other worse pandemics that should be addressed. One of those worst pandemics is obesity. It fights us on many levels, especially on fertility, as we as gynecologists, on fertility, PCO, pregnancy, menopause, and even in the incidence and the progress of cancers. Thank you very much for your attention.
Thank you very much, Professor Dr. Hussam, for this resume about the effect of obesity in women's health. I think this is the questions in Azhar University MD degree. Yes, and you had a good answer. Okay. Okay, thank you.
Okay, it's my pleasure now to introduce Professor Asim Saif, Professor of Endocrinology at Cairo University, and he's going to speak about liraglutide, one of the new medications that have been developed to fight the pandemic of obesity, and he's going to take us through the results and the efficacy of this treatment.
Yeah, thank you, Mr. Chairman, and بشكر الاورجنايزنج كوميتي على دعوتي وشركه نوفو على ان انا اكون معاكم النهارده، وانا علشان الوقت يعني هحاول ان انا الخص الموضوع. احنا هنتكلم على التريتمنت اوف اوبيزيتي، واحد اهم الميديكيشنز المتوفره دلوقتي هو اللايواجلوتايد او الساكسند. اول حاجه نتكلم على الاوبيزيتي تريتمنت اوبشنز. هي الاوبيزيتي از كرونيك ريلابسنج ديزيز، ويجب كلنا نؤمن بكده، وله كومبليكيشنز. ف يحتاج تريتمنت، والتريتمنت دي بتحتاج ان احنا نستمر عليها لفتره. فايه الاوبشنز اللي قدامنا؟ زي ما احنا شايفين انه ايا كان البي ام اي اكتر من 25، كل الناس اللي البي ام اي بتاعهم 25 او اكتر المفروض ان هم يبقوا على لايف ستايل ميديكيشن، لايف ستايل موديفيكيشن بروجرام، اللي هو دايت واكسرسايز. وطبعا في تفاصيل كتيره، ممكن الاكسرسايز ده يبقى حوالي 150 دقيقه في الاسبوع متقسمه على 5 أو 7 ايام. والدايت بتحتاج فريكوانت سمول ميلز وهاي فايبر كونتنت، ودي بتحتاج نيوتريشن بلان، ودي لكل الناس البي ام اي بتاعهم اكتر من 25. طيب مين ده يضاف اليها طبعا behavioral modification، ان احنا نحاول نغير عادات المريض علشان يبتدي يعيد تنظيم حياته ووجباته وحجمها ومواعيدها. مين اللي هيحتاج ميديكيشنز؟ هيحتاج ميديكيشن زي ما احنا شايفين، اللي هو البي ام اي بتاعه هيبقى فوق ال 30 او بي ام اي فوق ال 27 وعنده other obesity related comorbidities، عنده diabetes وبعض الكومبليكيشنز اوف obesity اللي تحتاج ان انا اقلل البي ام اي. وهنشوف ايه الفارماكوثيرابي اللي متاحه، وهي يعني للاسف سو فار في مصر ما هياش كتير قوي. مين اللي هيحتاج سيرجري؟ اللي عنده morbid obesity اللي البي ام اي بتاعه اكتر من 40، او لو كان اكتر من 35 وعنده adiposity related complications، او اللي فوق ال 30 في بعض الاحيان لما يكون عنده complications من الاوبيزيتي وكمان ما استجابش للعلاج. طب ايه هي الفارماكوثيرابي المتاحه؟ هنلاحظ ان في مصر في حاجتين بس المتاحين، الاورليستات اواصل زانيكال وبدائله المحليه كلها والجينيريك، وهي دي بتشتغل على الانرجي ويستد، بتقلل الابزوربشن اوف دي فات في الدايت بنسبه 30%، ولكن عيبها لو الدايت فيها فات كونتنت كتير هتعمل دايريا، وكل اللي استعملوها عارفين انها ممكن تكون مزعجه. البديل الثاني المتاح في مصر وهو بيشتغل على الابيتايت ريدكشن وهو اللايواجلوتايد اللي عايزين نتكلم عنه، وكل ده طبعا بالاضافه لللايف ستايل موديفيكيشن اللي هو الدايت اند اكسرسايز. طيب ايه هو دور الجي ال بي 1 اللي هو اللايواجلوتايد او جي ال بي 1 ريسبتور اجونست؟ ايه هو دور الجي ال بي 1 في الابيتايت ريجليشن؟ الجي ال بي 1 از ا بيبتايد من 31 امينو اسيد member of the incretin family secreted predominantly من ال cells in the gut ومن ال nucleus tractus solitarius في البرين. بس هنلاحظ حاجه مهمه جدا تحت على اليمين، انه الهاف لايف بتاعته دقيقتين. يبقى اذا الناتشورال فيسيولوجيكال جي ال بي 1 الهاف لايف بتاعته دقيقتين، وده طبيعي انه دايبيبتايل بيبتايديز انزيم يكسر الجي ال بي 1 علشان ما يبقاش موجود لفتره طويله. هنلاحظ ان هو بيزيد مع الاكل، بيزيد with meals علشان يعمل functions معينه، منها to delay الجاستريك emptying وده جزء مهم من عمليه الدايجيشن، ويساعد على انه يستيميليت البانكرياس انه يطلع انسولين فيساعد بعد كده انه السكر ما يعلاش، وبعد كده يبقى على طول ميتابولايزد بالدي بي بي 4 انزيم وبالتالي ما يبقاش موجود في السيركيليشن. السلايد دي بقى مهمه جدا، وده ريفيو ارتكل يعني معمول جوينت ورك بين جامعه كوبنهاجن وستينو انستيتيوت، بيوضح الفرق بين الفسيولوجيكال ليفل بيعمل ايه من الجي ال بي 1 باللون الاخضر، والفارماكولوجيكال ليفل اللي بيعمله الجي ال بي 1 ريسبتور اجون. هنلاحظ فرق مهم جدا، الفسيولوجيكال ليفل اللي بالاخضر بيعمل فوائد كتيره جدا على البانكرياس وعلى البرين وعلى الاستومك والكدنيز والليفر، ولكن النقط اللي بالاحمر دي فيها حاجتين مهمين. على البرين الفارماكولوجيكال دوز من الجي ال بي 1 ريسبتور اجونست بتعمل ايه؟ بتقلل ريورد ايتنج، ريورد بيهيفير، وده مشكله كبيره جدا في الاوبيزيتي، ان المريض بيكافئ نفسه. انا النهارده عملت مجهود كبير، اشتغلت كويس، نجحت، يبقى لازم اكافئ نفسي، انا مش جعان ومش عايز اكل ولا اي حاجه. لكن ريورد ايتنج، ريورد بيهيفير بتاعي بيقول ان انا لازم اخد سويتس او اكل حاجات هتزود الوزن او هترفع السكر. ده اللي بيشتغل عليه الجي ال بي 1 ريسبتور اكس، بالاضافه الى الكارديو فاسكولار بروتكشن اللي ما بيتحققش الا بالفارماكولوجيكال دوز من الفارماكولوجيكال ليفل من الجي ال بي 1 اللي بيوفره الجي ال بي 1 ريسبتور اجونست، وده الفرق بين الفسيولوجيكال والفارماكولوجيكال ليفلز من الجي ال بي 1. له الجي ال بي 1 ريسبتور اجونست زي ما احنا شفنا كده له مالتيبل فانكشنز او مالتيبل افكتس على البرين، يزود الساتيتي ويقلل الريورد ايتنج زي ما قلنا. على الاستومك يقلل الجاستريك امتنج، يديلي الجاستريك امتنج، وده اللي بيخلي الواحد يحس بالفولنس، فما يحسش ان هو جعان بسرعه، يحس ان هو شبعان لفتره طويله بعد الاكل حتى لو كل كميات قليله ومش عايز ياكل كميات اكبر. على البانكرياس يزود البيتا سيل فانكشن والانسولين سكريشن، ويقلل الجلوكوز ديبندنت جلوكاكون سكريشن. وعلى الهارت بيعمل الكارديوفاسكولار بروتكشن، طبعا له تفاصيل كتيره. وعلى الليفر ان هو حاجه مهمه جدا يقلل الاندوجينوس جلوكوز برودكشن، ودي من الحاجات اللي احنا بنشوفها دايما في المرضى الدايابيتس والبري دايابيتس. الفاستنج بلاد شوجر يبقى عالي. عالي ليه؟ لانه بالليل الهيباتيك جلوكوز اوتبوت كتير، عشان كده بنقول للمريض اثر الساعات اللي تبقى صايم فيها، تاكل سناك قبل ما تنام، تفاحه قبل ما تنام، وتفطر بدري، فما يبقاش في فتره طويله الليفر يطلع جلوكوز برودكشن كتير. وده كمان بيقللوا الجي ال بي 1 ريسبتور اجونست، يقلل الاندوجينوس جلوكوز برودكشن، بالاضافه انه يحسن الهيباتيك انسولين سنسيتيفيتي. طيب اللايراجلوتايد بقى 3 مللي جرام اللي هو الهيومن جي ال بي 1 ريسبتور اجونست او انالوج، 97% سيميلر للهيومن للناتشورال جي ال بي 1. هنلاحظ ان هو ليه افكت مهم جدا على الساتايتي، ان هو بيزود الساتايتي ويقلل الهنجر عن طريق تاثيره على الجابا والاركت نيوكلاس في البرين. وحاجه مهمه جدا هنبص بقى تحت على الشمال على الهاف لايف اللي كانت دقيقتين في الناتشورال فيسيولوجيكال ليفل اوف جي ال بي 1، هنلاقي هنا 13 ساعه. يبقى التغيير في الاستراكشر بتاعه هدفه ان هو يبقى ايه؟ ان انا هدي فارماكولوجيكال دوز وان يبقى ليها لونج لاستنج افكت لفتره طويله، عشان كده اقدر اديه مره واحده في اليوم. ليه؟ لان انا قدرت امنع الرابيد ميتابوليزم من الدي بي بي 4 انزيم. يبقى انا قدرت ادي فرصه اطول للجي ال بي 1 ليفل انه يبقى موجود، وكمان الليفل بتاعه فارماكولوجيكال يعني اعلى من الفسيولوجيكال ليفل. هيعمل ايه اللايراجلوتايد 3 مللي جرام؟ هيعمل لوس اوف بودي فات ماس، يقلل الانرجي انتيك، يقلل الفود كريفنج، ويكنترول الايتنج. يبقى انا بشتغل على البرين وكمان بديلي الجاستريك امتينج، فبحسس المريض بالفولنس، وكمان له اكسترا بنفيتس زي انه يحسن الانسولين سكريشن، وانه يقلل الجلوكاجون والكارديوفاسكولار بروتكشن. سكيل بروجرام باختصار اللي هو الترايل بروجرام اللي اتعمل على اللايراجلوتايد 3 مللي جرام ساتايتي اند كلينيكال اديبوزيتي لايراجلوتايد ايفيدنس. كان في 6600 مريض. وباختصار من ناحيه الافيكاسي هنا الرقم ده مهم جدا، 70% من المرضى كانوا early responders. يعني ايه early responders؟ يعني بعد 16 اسبوع فقدوا 5% او اكتر من البودي ويت، وهو ده المريض اللي احنا بنكمل معاه. بنبتدي باسكاليتنج دوز زي ما انا هعرض دلوقتي. بعد 16 اسبوع بنقيم، لو المريض lost 5% او اكتر من البودي ويت يبقى هو ده الايرلي ريسبوندر اللي هكمل معاه. لاكلي انف دول 70% او اكتر من المرضى اللي هياخدوا اللايراجلوتايد. اللي مش هيفقد 5% في خلال ال3 شهور او 16 اسبوع الاولانيين يبقى ده مش هيستفيد من الدواء ولا داعي ان انا اكمل معاه. هنلاحظ انه الايرلي ريسبوندرز بيفقدوا لحد 11.5%، يبقى اللي استجابوا وفقدوا 5% في اول 16 اسبوع لما بكمل معاهم ل 56 اسبوع اكمل سنه ممكن يفقدوا 11.5%. ده افريج، في ناس بتوصل ل 15%. انا عندي مرضى كانوا 125 و130 كيلو، لما نزلوا 15% اتغيرت حياتهم تماما. فيهم ناس كانوا بري دايابيتك رجعوا الى النورمو جلايسيميك رينج زي ما هنشوف. الايرلي ريسبوندرز بعد 16 اسبوع فقد 5% او اكتر من وزنه، هكمل معاه هقدر اوصل بعد سنه ويمكن قبل كده الى 11.5% ويمكن اب تو 15%. بس لازم احط للمريض يعني ريزونبل اكسبكتيشنز، فاحنا بنتكلم على 8% 10% عشان المريض ما يتصورش دايما ان كل الناس هتفقد 15%. 55% of the early responders achieved more than 10% weight loss. دي نسبة كبيرة جدا، أكتر من نص الأيرلي ريسبوندرز وصلوا لأكتر من 10% ويت لوس بعد 56 أسبوع أو بعد سنة. ده بقى اللي انا بقول لكم عليه، اللي هو من اهم الحاجات اللي احنا بنشوفها في شغلنا في الاندوكرينولوجي، انه 80% relative risk reduction in developing type 2 diabetes. يعني معناها ايه؟ معناها ان المرضى البري دايابيتك اللي هم اوبيز، اللي هم عندهم هاي ريسك ان هم يبقوا دايابيتك خلال السنوات اللي جايه، لما بديهم لايراجلوتايد واقدر امشي فتره كافيه ممكن توصل ل 160 اسبوع، يعني 3 سنين، ممكن جدا ان انا انزل احتمال اقلل الريسك ان هم يبقوا دايابيتك بكام؟ 80% 80% relative risk reduction، وده احنا شفناه كتير في المرضى اللي عندهم fasting hyperglycemia او post prandial hyperglycemia ما وصلوش للدايابيتس رينج، هم لا زالوا بري دايابيتك ولكن عندهم هاي ريسك اوف كارديوفاسكولار ديزيز، هاي ريسك انهم يبقوا دايابيتك. نقدر نرجع 80% منهم، نقلل 80% ريسك ان هم يبقوا دايابيتك، وده اتشيفمنت كبير جدا ان المريض مجرد انه يفقد 10 11 15% من البودي ويت انه يقدر يبقى نورموجلايسيميك تاني، ولو قدر يحافظ على الوزن ده ممكن جدا يأخر انه يبقى دايابيتك ويمكن ما يبقاش دايابيتك ات اول. وده زي ما احنا بنقول انه 2.7 years more needed to develop type 2 diabetes for patients using liraglutide 3 ملغ. يعني لو ما قدرتش تمنع انه يبقى دايابيتك هتاخر ان هو يبقى دايابيتك ب3 سنين، وده في حد ذاته بيديله فرصه، لان كل ما هيبقى دايابيتك بدري معناها ايه كارديوفاسكولار كومبليكيشنز اللي بتدي اوريدي قبل ما يبقى دايابيتك. هنا هنبص بقى نلاقي انه ايه تلتين المرضى ريجريس تو نورموجلايسيميا اوفر تايم، وهنلاحظ هنا انه الريجريشن ده ابتدى من بدري من الاسبوع 28. عند الاسبوع 28 بيبتدي الريجريشن، وده اللي بنشوفه فعلا، وانه مينتيند لتلتين المرضى لحد ال3 سنين او ال160 اسبوع. فكون يقدر ارجع تلتين المرضى الى النورموجلايسيميا ده اتشيفمنت كبير جدا في المرضى اللي هم اوبيز اند بري دايابيتك. وحاجه من الحاجات المهمه اللي هي الكارديوفاسكولار سيفتي او الكارديوفاسكولار بروتكشن. برضو انا مش عايز ادخل في تفاصيل الكارديوفاسكولار اوتكم ترايلز، لكن الاف دي اي في امريكا بتشترط انه كل دواء جديد للسكر او لتقليل الوزن او في الفيلد ده لازم يثبت ان هو سيف من ناحيه يثبت كارديوفاسكولار سيفتي، فدي نون انفيريوريتي ترايلز، يعني الهدف انه ما يكونش بيضيف ضرر. بعض الادويه ومنها اللايراجلوتايد ثبت ان لها السوبريوريتي، انها بتعمل كمان بروتكشن، وده اللي بان هنا في الكارديوفاسكولار اوتكم ترايل بتاعت اللايراجلوتايد اللي هي الليدر ترايل، انه الكارديوفاسكولار ديث والنون فيتال مايوكاردال انفاركشن والنون فيتال ستروك، وخلي بالنا النون فيتال مايوكاردال انفاركشن والنون فيتال ستروك دول مزعجين جدا زيهم زي الكارديوفاسكولار ديث. المريض اللي بيجي له ستروك ويبقى كريبلد ده بيأثر على حياته هو وعيلته والكوميونتي، وتكلفه عاليه جدا على المنظومه الصحيه. اذا قدرنا نبريفنت ده او نقلله يبقى كويس جدا. دولت اللي بيسموهم ميجور ادفيرس كارديوفاسكولار ايفنتس او ميس. الثلاثه دول قلوا بنسبه كام مع اللايراجلوتايد؟ 13%. يبقى اللايراجلوتايد قدر يقلل الكارديوفاسكولار ديث، النون فيتال مايوكاردال انفاركشن، النون فيتال ستروك ب 13%، وهنلاحظ هنا ان الهازارد ريشيو 0.87، يعني قللت الريسك بنسبه 13%. ده طبعا اضافه ليه؟ لان مطلوب من الكارديوفاسكولار اوتكم ترايلز انه يبقى نون انفيريور، لا هو اثبت انه سوبيريور، وبيضيف انه كمان غير انه هيعمل الويت ريدكشن وهيعمل الجلايسيميك كنترول انه هيعمل كارديوفاسكولار بروتكشن. وهل ده على حساب سايد افكتس سيفتي وايز؟ الجاسترونتراين سايد افكتس كلها محتمله ويمكن هنتكلم هاو تو هاندل. ما ظهرش ابدا اي حالات ميدالري ثايرويد كارسينوما في الهيومن بينجز، هي ظهرت في اللاب راتس فقط، ولكن في الهيومن بينجز هي ما ظهرتش. ولكن لازال احنا بننصح عموما انه اللي عنده فاميلي هيستوري اوف ميدالري ثايرويد كارسينوما او بيرسونال هيستوري للميدالري ثايرويد كارسينوما فقط هو ده اللي ممكن يفضل ان هو ما ياخدش لايراجلوتايد على الرغم من عدم ظهور حالات في الهيومن بينجز. نيو سايكاتريك مانيفستيشنز زيها زي بقيه الادويه نيوترال. بالنسبه للجاسترونتراين سايد افكتس لانه بيعمل ديليد جاستريك امتينج لازم هيعمل فولنس ونوزيا، فعشان كده احنا بنبتدي جراديولي ب 0.6 ملغ ديلي سبكوتينيوس انجكشن بالقلم ده اللي هو الفليكسي تاتش اللي سهل جدا استعماله، وبعد اسبوع نزود الدوز الى 1.2، بعد اسبوع الى 1.8، بعد اسبوع الى 2.4، وبعد اسبوع نوصل للماكسيمم دوز 3 ملغ. لو المريض ما قدرش انه يتحمل ال 3 ملغ دوز يبقى ممكن نقلل الى 2.4، لكن لو احنا شرحنا له انه النوزيا دي متوقعه وانها هتروح مع الوقت وانه محتاج تو ايت لس كميات اقل، يشرب ميه كتير وتو ايت سلولي، هنبص نلاقي انه هيقدر يتوليريت النوزيا، وخلال اسبوع نقدر نزود الى الجرعه الاعلى لحد ما نوصل للماكسيمم دوز، لان اذا قدرنا نوصل للماكسيمم دوز ونمنتينت ده هيجيب النتائج اللي احنا شفناها اللي هي الرينج بنتكلم في 8 الى 15%. بس المهم انه الايرلي ريسبوندرز اللي بيفقدوا 5% من البودي ويت او اكتر خلال اول 16 اسبوع هم دول اللي هيستجيبوا كويس جدا، وبنكمل معاهم عشان نوصل للنتائج اللي احنا شفناها سواء من ناحيه الويت لاس loss او ال cardiovascular protection او ال reversal او even remission of diabetes او نرجع ال pre-diabetic الى ال normoglycemic range. Thank you.
Thank you, Professor Asim, for this excellent presentation. I think all of us need this drug.
Sure. واحنا we have to believe انه obesity is a chronic relapsing disease with complications. فده الاساس يعني الكونسبت ده once we believe in خلاص يعني بعد كده هنفهم how to handle it.
I will ask you about this drug is suitable for all age in adolescent or below adolescent stage.
Yeah. We used to start it from 12 years. 12 years, yeah.
Right.
And it helped actually to prevent and delay type 2 diabetes in obese adolescents with pre-diabetes. لأن احنا بنشوف من دول كتير دلوقتي يعني اللي انا بقول عليه عصر بقى ما بعد ماكدونالدز وكنتاكي بنشوف طبعا اوبيزيتي في الادوليسنس كتيره جدا وفي ناس منهم عندهم فاميلي هيستوري اوف تايب 2 دايابيتس وهم بيبقوا بري دايابيتك واتعمل طبعا استادي على الادوليسنت تايب 2 دايابيتس وقد ايه هو مزعج على المدى القصير والكومبليكيت فكل ما نقدر تو ديلي دايابيتس في المرضى الادوليسنس دولت that would be an achievement.
And about the heart disease patient, it is safe in heart disease patient.
Yeah, it's safe actually and it gives cardiovascular protection. هو بس يعني the most important is to make sure انه لو في سبب للobesity endocrinal cause of obesity to be treated لانه sometimes المريض بيبقى hypothyroid فنلاقي المريض مش مستجيب ابتدى مثلا في nutrition clinic واتضح انه ما اتعملوش thyroid functions فاول حاجه لازم نعمل assessment للthyroid functions نتاكد لو المريض hypothyroid ياخد علاج لو في احتمال او manifestations suggesting Cushing disease for example بنعمل اليورين كورتيزول 24 يورين كورتيزول ونتاكد ما فيش endocrine cause للobesity to be treated before starting liraglutide 3 mg او السكسن.
Thank you very much.
Thank you. Thank you.
Now came to the end of this session. We'll start the parallel session, 4 parallel session now. Thank you.